is Dr. Vaijayanti Lagu-Joshi. Madam is a senior consultant rheumatologist and chief coordinator, Department of Rheumatology in the Nanath Mangeshkar Hospital, Pune. I remember Madam being a part of this MBM from past 6 to 7 years, along from the time of inception of this SYNAPSE. She is member of American College of Rheumatology, member of Indian Rheumatology Association. She's working in Dinanath Mangeshkar Hospital from 2007 till date, and she's ex-visiting faculty for Rheumatology Fellowship in Bharati Vidyapith Hospital. She's got many awards, credits at her credits, and her academic and social activities are many, but I think this is few which has been listed on the slide. So with this introduction on the screen, I would like to invite Madam to start the first session. And her topic for today is so heavy matters, the weight of obesity in rheumatic disease. So welcome, Madam. Over to you.
Thank you. Thank you, Dr. Geeta, for that kind introduction. And good morning to all of you. It's always a pleasure to come in the forum of SYNAPSE and meet different people, different fraternities over here, and share our experiences or knowledge with them. So today, we are all dealing and listening to the obesity and different aspects of obesity all those 4 days. And it's nice to see you all this morning. Being the last day of the conference also, you're there. So I'm very thankful to you also. So yes, heavy matters. The weight of obesity in rheumatic diseases is my topic today. So if you know, the world is going through all crises right now. Yes, be it a COVID crisis, what we experienced in 2020. After that, there's a war crisis recently. And yes, there's one more crisis going on in the medical field, and that is the obesity crisis. So almost 1 in 8 people, they are documenting to be obese or overweight. And this obesity is really going rampant. The adult obesity is seen to be doubled than what we are seeing in 1990. But the more worrisome part of this is the growing obesity in the adolescents or childhood obesity. It is almost quadrupled than what we were seeing in 1990. So definitely it is a matter of worry now. And as we know, obesity is a complete package. So it doesn't come alone as the obesity, but it brings along with it different medical disorders. In that, we have seen so far yesterday hypertension, type 2 diabetes, then this cardiovascular diseases. Along with that, you must have talked and listened to the psychology people and psychiatrists and the neurologist about the brain and the mind part. And today's time, we also talk about the musculoskeletal system and the musculoskeletal system disorders associated with obesity. So, obesity is a complex and ongoing disease, and definitely it is a relapsing disease. That's why you have to be on toes for managing the obesity. And as I mentioned in the slide, that obesity is one of the important risk factor for different rheumatic and musculoskeletal diseases also. So this fat, muscle, bone, they are forming a kind of metabolic axis that contributes to obesity, and that is also having some problems because of the obesity. And after all, why we are all talking about the obesity is not just the physical or the mental burden, but it is an economic burden on overall society. So these are the few musculoskeletal conditions I have listed. I'll be touching upon a few out of them. The osteoarthritis, that is a wear and tear arthritis, what we were listening to, and these are of knee, hip, and hand. Low back pain, a very chronic issue in the society and very common. Then diffuse idiopathic skeletal hyperostosis. Then conditions like gout. Then few of the rheumatic musculoskeletal problems like rheumatoid arthritis or the spondyloarthritis, which also face problem with the obesity. Then there are soft tissue conditions also, like carpal tunnel syndrome, plantar fasciitis, or heel pain, which are very, very common. So this is a table just of BMI or the weight gain what the patient has. Along with that, the radiographic progression and the irreversibility of the event. That is very, very important. And the last three conditions, the rheumatic arthritis and spondyloarthritis, do have some studies showing a very good connection between this obesity and these problems. And definitely we are finding that this relations or treatment is suboptimal in all those conditions when the patient is obese. So definitely obesity matters in the management of all those rheumatic musculoskeletal conditions. So what are the possible mechanisms by which the obesity affects this musculoskeletal system? These are the few mechanisms. First and foremost, what is very logical is this biomechanical, where the stress or the weight what the obesity carries on the weight-bearing joints, especially the knee, hips, spine, definitely that causes more load on the bones, joints, and the muscles. Then the inflammation is a new thing coming up, and that is a chronic low-grade inflammation, what we are talking about in last 3 days. And that definitely affects the joint structure, the joint organization by this inflammatory cytokines. Third mechanism is an altered gait and the postures. Dr. Namrata will be talking in a short while more on these postures and the exercise part and the gait part. So definitely weight disrupts this normal gait and normal balance mechanisms. Then there is a reduced mobility with the obesity, which causes more wear and tear and limitation of physical activity and sarcopenia and increased injury risks. So all of those mechanisms are contributed by obesity on these musculoskeletal conditions. Coming to the epidemiology of the osteoarthritis, yes, these Copcot surveys have shown us that the osteoarthritis or degenerative wear and tear arthritis are the dominant part what the community is suffering, and less than 10% cases are suffering from actually the inflammatory arthritis what we see. So out of this graph, yes, you can see that the dominant part is this, the osteoarthritis. 34.1% of the population of the cases are having mainly the osteoarthritis thing. Along with that, some ill-defined aches and pains, followed by very less amount of inflammatory arthritis. So as rheumatologists, we are also bothered about management of this osteoarthritis. But now there is a time where we are reframing this concept of osteoarthritis. It is no more a wear and tear kind of arthritis, but yes, the inflammation is also has its position in the pathophysiology of the pathology of the osteoarthritis. So obesity is the one which has transitioned from a systemic kind of metabolic problem to a localized damage within the joints. So that is an absolute paradigm shift from mechanical wear and tear of the tissues to the abnormal mechanical loading and systemic immunometabolic mechanisms which are contributing to the arthritis. So this is mainly in the form of breakdown of the cartilages and the surrounding joint architectures, which is seen with osteoarthritis knees, spine. There is ossification of ligaments around the spine. So what is a common link between the diseases now? So be it a disease like Alzheimer's, Parkinson's, myocardial infarction, coronary vascular diseases, diabetes, hypertension, osteoarthritis? Yes, there's one common link which is joining all the dots together, and that is an inflammation. It has been thought long before, almost 2004 Time article, Time magazine has given this highlight, that this is the silent killer, and joining all the dots together, what the diseases are coming up as chronic diseases. So this is that osteoarthritis. I'm sorry about this slide, but I think you can visualize on the screen well. But these are the osteoarthritis we commonly see. The elderly ladies or elderly people or senior citizens who are walking with a waddling gait and have this kind of osteoarthritis knees, the varus kind of postures, what they land up with because of the degeneration of their knee joints. The elderly people who are bowed forward because of the kyphosis of the spine, that's osteoarthritis spine. Then there is osteoarthritis hips also, which is a main weight-bearing joint for the body. But apart from that, this osteoarthritis of distal interphalangeal joints, DIP nodes, that's an interesting thing. They are not weight-bearing joints, but still we do get the osteoarthritis process over there. And that's why the inflammation hypothesis or inflammation theory becomes an important part. So these obesity-related mechanical changes are the ones which are affecting those weight-bearing joints. So there is an overload. Apart from that, there is a malalignment, what I showed in the picture, the varus kind of malalignment, that more adds to the deformation of the joint. With that overload and abnormal loading, there is loss of cartilage, there is a loss of bone remodeling balance over there, and that all leads to the cartilage degeneration, the subchondral bone deterioration, there are changes over there also, and the surrounding tissue changes. So joint is also looked upon as an organ with all those surrounding tissues, cartilage, menisci, ligaments, and all of them getting distorted because of this abnormal loading. And obviously the muscle weakness along with that which comes, and that adds to the instability of the joint. But as I said, this is not just enough to explain the osteoarthritis at other points like carpometacarpal joint or this distal interphalangeal joint. And here comes the link of obesity and inflammation. So the obesity results from the excessive deposition and increase in the adipocytes. And these hypertrophied adipocytes act as an endocrine organ which release different cytokines, adipokines, which are pro-inflammatory in nature. The body always tries to balance between pro and anti-inflammatory, but there is macrophage shift also, polarization also, that also adds fuel to the already burning of that particular joint. So this pro-inflammatory cytokines in form of TNF-alpha, interleukin-6, then leptin, adiponectin, they are all responsible for adding that fuel, while adiponectin in some form and omentin are the anti-inflammatory cytokines which are trying to balance this. So it always matters the location of the fat and the function of the body fat. So it is always the subcutaneous and the visceral and the intra-organ fat deposition which matters a lot in osteoarthritis. And as I said, this macrophage switch is supposed to be one of the key elements in contributing this osteoarthritic phenomenon, and this switch to M1-like phenotype, and these cells are there present in the synovial membrane of the joints and lead to further inflammatory cascade. So this meta-inflammation, what we can call, link between the metabolic factors and the inflammation, and a crosstalk between the two, and it is seen in different organs. It not just happens with the adipose tissue, the joints, but also in the liver, muscles, brain, and gut. So adipocyte dysfunction is a very, very important phenomenon which leads to this local inflammation and then insulin resistance throughout the body. So as we were thinking that all those elderly people coming to our OPDs, no, this is not true. So we are getting now people of young age, almost 30s and 40s, who are coming up with knee pain and osteoarthritis, knees and spine. Here's that case, 36-year IT professional, typical sedentary lifestyle, absolutely, and working for long hours in sitting postures, coming with knee pain on and off since 2 to 3 months, had gained weight recently, 14 kgs. On examination, he was morbidly obese, BMI of 34.41 with mainly the central obesity, abdominal girth high. Then was showing blood pressure of 150/100, no active synovitis on our examination or no deformity in the joints yet. Mild knee varus I mentioned because the x-rays are showing that. So on investigating, definitely again he's showing all the lab abnormalities of metabolic syndrome. So there is a CRP which is elevated. Then there is mild transaminitis. Then we can see the definite uric acid elevation. Yesterday we were talking much about this hyperuricemia. Then this cholesterol and lipid derangement. but all other rheumatological lab was absolutely normal. And this was his X-ray showing this early varus deformity and the joint space reduction. Then comes, so that's why this particular phenotype is being labeled as metabolic syndrome associated osteoarthritis. So this is a new entity or new phenotype of osteoarthritis, which is coming in young people. So the generally age group is 45 to 60, and these are overweight, obese, along with some other factor like hypertension, dyslipidemia, type 2 diabetes, the insulin resistance. And this all initiation and progression of OA is through these adipokines, the inflammation, insulin resistance. So these are the mechanisms how the obesity is related to the osteoarthritis causation as well as progression. So first corner, left corner, the mechanical stress, which is directly acting on the chondrocytes. Chondrocytes are the one which are responsible for cartilage generation. So those chondrocytes, they show apoptosis, senescence with this mechanical loading. Then the adipokines we mentioned, those are the inflammatory cytokines which are there in form of leptin, resistin, bisphatin, which are adding to chondrocyte apoptosis. Then the synovial inflammation. Then the lipid metabolic disorders, the oxidized LDL, then saturated fatty acids, they are all contributing to this extracellular matrix degradation. And that's how the inflammation further aggravates and it leads to the destruction of the cartilage in between the joint, and that's how the joint spaces collapse and the osteoarthritis is a result. And these adipose tissue macrophages, they are also one of the important factors in contributing to this inflammation. So in research trials, they have shown that there is an association of the leptin, what is being already always talked about, that leptin levels in the infrapatellar fat, that is very, very important while giving rise to those inflammatory cytokines. The plasma and synovial fluid leptins, they have shown association with the radiographic severity and the aggravation of the osteoarthritic process. So all in all, these metabolic diseases are definitely having a negative and a cumulative impact on the osteoarthritis process. So right from the pyramid, the base level, the obesity, which is a starting point, where we get this meta-inflammation in the adipokines, the cytokines, then there's a mechanical stress. With top of that, you have the type 2 diabetes that is responsible with insulin resistance. Then there is a high glucose exposure. There are formation of advanced glycation end products, which are the culprits for actual destruction of the cartilage also. Then there is a dyslipidemia in form of this oxidized LDL, and that causes the increased local inflammatory milieu, and the hypertension, which adds to the subchondral ischemia, which leads to the changes in the subchondral bone as well. So all in all together, more the merrier, so they land up with more destruction of the joints. Now coming to backache. Backache has been a very, very common problem in the community, what we see. There won't be a single person right now over here also who has not experienced backache any time in their life. So that's a very, very common issue, and many a times we see that the backache is a chronic problem. It is not just acute one-time problem, but people do linger with this low backache for years together and months together. So yes, the obesity definitely is responsible, one of the responsible factors, an independent determinant of the chronicity of the event. It definitely has the degeneration of the intervertebral discs and degeneration of that cartilage. And along with that, there are bone changes, this formation of those osteophytes, and the mechanical stress. And along with that, there is a muscle deconditioning. That is very, very important aspect to be addressed again. And more of the neurological signs, what we see with the compression of the nerves, that is seen with in the obese people. So this is how the lipid metabolism disorder, the adipokines, the inflammatory cytokines All of them have the, again, action on this osteogenic differentiation, and that leads to not only the degeneration of the cartilage, but also the overgrowth of osteophytes and the ossification of spinal ligaments, further restricting the mobility. Here's a 46-year-old IT professional again, and having obesity for almost 15 years. A sedentary lifestyle, absolutely faulty dietary habits. He's been diagnosed with hypothyroidism and dyslipidemia way back in 2017. And he had his autoantibodies positive for thyroid. He was under endocrinologist care, but very irregular follow-ups and medication, not really following. Now referred from an endocrinologist to me for backache since 6 months and the hyperuricemia. Actually, the purpose for referring to me was hyperuricemia for last 8 to 9 years. So on clinical examination, he was morbidly obese, weighing 130 kgs now. But musculoskeletal examination was showing lumbar lordosis, no knee deformity as such, no active synovitis. Then this range of movement, what we look for, that was also fine. Mild restriction only in the lumbar region. There were no suggestion of gout because the patient was referred for hyperuricemia. Generally, the first metatarsal joint, then the other episodic kind of arthritis, he was not really having those symptoms. On investigation, he was surprisingly having a glycemic index of 5.1. ESR CRP not very high, very mild. Mild transaminitis, uric acid was in the range of 7.9, just above the normal. The X-ray was very bad, but you can see this, the long sedentary habits, no exercises at all, and this obesity going on and on. This last table is showing his progress of weight. It's not working. Pointer is not there, okay. But if you can see that the year 2017, I've just plotted his weights and his some of the lab parameters. And we can see that he was weighing almost 111 kgs in 2017. With jump to in 2021, he went to 113 kgs. Then there was a COVID time. We all had experienced the sedentary lifestyle that time. And almost in 2022, he jumped from 113 to 124 kgs. Then he was absolutely irregular in between and has landed up in December 2025 to an endocrinologist with a weight of 140 kgs this time. Yes, obviously, he was started on injection Mounjaro, and that's how we can see the change in the weight now. So in March 2026, he's weighing 137, followed by right now in July, he's on 130. So he's lost almost 10 kgs in last 6 months, we can say. But meanwhile, all his blood pressure parameters are also showing on a higher side. So 2022 onwards, he is maintaining his blood pressures on the higher side, 140, 100, then now also 150, 100. It started on already antihypertensive medications. And this was a third column with uric acid. Those levels have been around 8. So you can find it in 2017 also, it was around 8. Then 8.2, 8.7 in December, and now it has come down to just 7.9, but still having a persistent hyperuricemia, which is now supposed to be another marker of a metabolic syndrome, persistent ongoing hyperuricemia. Then definitely is also having the lipid derangements, the higher triglycerides, the cholesterol levels. So definitely the obesity causes the changes in the mechanics. There are postural changes. There is excessive kind of lordosis with which they walk. Then definitely there is some kind of pelvic shift and truncal sway. So you can make out from a distance that the obese person, how he's walking with a waddling gait. There's an impact is with the decreased spinal and hip flexibility. Then there is a chronic low back pain and increased thoracic kyphosis. So all those muscle imbalances, muscle weakness, inflammation, all of them do contribute to gait disturbances and postural instability. So apart from that, the postural instability and the changes in the mechanics occur in feet also. The very common fact known that female 40 postmenopausal, fat female 40, landing up with heel pain. So that heel pain is because of this plantar fasciitis, and that occurs with the flattened foot arches, then this pronation of the ankles, the impaired gait, and there is a change in overall the mechanics of weight distribution on the feet. So that's why this is also a very chronic and a very common problem in females or fat females or obese females. Along with that, there's some other soft tissue pains as well, trochanteric bursitis. This is the tendinopathy, what I'm labeling referring to. And this is also a very common thing what we find in obesity as well as type 2 diabetes. The commonest tendons which are affected are rotator cuff tendons in the shoulder and the tendo-Achilles tendons in the feet. So the contribution is by the accumulation of advanced glycation end products, then the adipokine secretions which are occurring locally because of the obesity, dyslipidemia and tendon ischemia because of the hypertension and hyperlipidemia. And it is a cycle. So there is pain, that's why there is an inactivity. There is inactivity, there is a weight gain. And once weight gain, again that lands up with the more pain. So all of them are kind of a vicious circle because of obesity. Coming to these other problems like gout, fibromyalgia, then diffuse idiopathic skeletal hyperostosis, which is classically seen with diabetic patients, type 2 diabetes, carpal tunnel syndrome, where because of the obesity also we can get this compressive neuropathy leading to tingling, numbness, and paresthesias of the hands and pains. So coming to this one slide, because we had a lot of discussion on this hyperuricemia yesterday, I want to make few statements over here that hyperuricemia is both a consequence as well as contributor to obesity. Asymptomatic hyperuricemia is not synonymous with gout. So all those patients with hyperuricemia are not gout. The largest, but they are largest risk factor to gout, yes. The prevalence of this metabolic syndrome is definitely higher in gout patients. Whenever we analyze the gout patients, they do have the other risk factors like obesity, hypertension, diabetes, and weight. So hyperuricemia predicts sometimes the future development of metabolic syndrome and type 2 diabetes. The higher BMI, especially the central obesity, is one which correlates well with the serum uric acid levels. But currently, there is no evidence to suggest or support the treatment of isolated hyperuricemia with urate-lowering agents because they are not showing any kind of improvement in per se the musculoskeletal outcomes. So management should always focus on the background metabolic syndrome, where the management should focus on weight reduction, lifestyle modification, treatment of hypertension, diabetes control, and dyslipidemia. Now coming to this, it's very interesting that obesity affects everywhere. It is not just the metabolic problems it causes or structural problems it causes. It can alter your pain processing. That is very, very important. And one of the fact which is coming up with fibromyalgia patients. So there is an altered pain processing because of these inflammatory cytokines also adding to that, and not at the peripheral level, but at the central level also. So in brain also they do have the affection of this somatosensory cortex, then the descending pathways of pain inhibition, they definitely affect. And that's why these patients do perceive a pain lot and they can have the fibromyalgia. So it's a very interesting case, 32-year unmarried lady. And she was an event management professional till 2020. But after COVID, unemployed. There are diffuse body aches and pains and knee pains for almost 1 year plus. Having some facial puffiness, malar flushes. That's why actually she came to me to rule out the other conditions like SLE or lupus. She had some episodes of angioneurotic edema in the past for which she used to take steroids. And somewhere she also was in a habit to take those steroids as and when needed, whenever it used to pain. But in past, she had this depressive illness for almost 10 years. We can understand post-COVID, unemployed. So 10 years she's been having this depressive phenomenon. Trigeminal neuralgias, for which she was treated with different modalities. Radiofrequency ablation also was done. She was also having diabetes and hypertension since 2017. In personal history, yes, she had chronic insomnia, a lot of sleep disturbances problem. The menstrual also, the hormone part was also not regular, and she was having this PCOD, irregular menses and periods. Was weighing 102 kg, BMI 36. She was Cushingoid when I saw malar flush, then facial puffiness, but there was no other rheumatological abnormality in form of arthritis, synovitis, myopathy, no mucositis, sicca, and this is to rule out the lupus part of it. Her lab showed some mild to moderate anemia. The HbA1c was obviously not controlled well, 9. The rest of the rheumatological immunological lab was within normal limits. Then thyroid was normal. ESR CRP mild elevation there. Then other metabolic lab was okay at the moment. X-rays were showing again some osteoarthritic changes early and fatty liver. And this was a prescription which she had come to me. So if you can look at the left-hand corner and the right-hand corner, it's almost 20 medications and pills what she was taking on when she attended me. And now she was there in front of me to add a few more medicines on that. So it was just ridiculous to address her with all those medications. So I just went behind the curtain. So there were some past stressors. Yes, there were parental conflicts while she was brought up in her childhood. Her mother passed away in 2007, and with multiple hospitalizations, she was very closely connected to her mother. No other family member she was very close to. She was very lonely that way. The present stressors were obviously she was unemployed and lonely with this obesity, then other metabolic problems adding up like diabetes, hypertension, then this chronic aches and pains which were ongoing, and the medication dependence. And on top of that, she was not ready and reluctant for psychiatric consultations. So definitely those patients are really, really difficult to manage. The chronic aches and pains they go through are like hell. But we really can't offer all from a medical pill or a medicine for those patients. So this is a typical central pain prone phenotype, where these are generally females, have some genetic predisposition, then there are early life traumas they are associated with the family history, then mood disturbances, then this personal history of chronic centrally mediated symptoms with sleep disturbances. So definitely, weight pain connection is not just a coincidental morbidity. No, the obesity definitely affects this fibromyalgia symptoms a lot. It causes the amplified pain severity on those patients because of the poor muscle conditioning with the obesity. Then there's a worsening sleep dysfunction. Then there is this pain inhibition pathways which are affected with this obesity and increasing depression burden. So this case becomes really challenging to handle because it is not just the addressing chronic pain over here with some analgesics or anti-inflammatory medications, but we have to address her insomnia, we have to address her depression, we have to address her obesity and metabolic syndrome. Unless and until I don't think we can give justice to her management. So it is a holistic approach what we need for such patients of fibromyalgia. Coming to treatment part of osteoarthritis, this was a typical pyramid what we used to learn, but no, nowadays the pyramid is almost ulta. So we are seeing mostly patients are undergoing fatafat joint surgeries, and TKRs and THRs is just as common as a cataract surgery what we are seeing now. But no, I think the basis of all the treatment of osteoarthritis starts from education, self-management. That is very, very important. Along with that, the exercise, the physical activity part, and weight management, that becomes very, very important. Because we are seeing patients who have undergone TKR and THR, but still are obese and really not doing well. So if you want a surgery outcome to be really better, then definitely the weight management comes first and will be there throughout the life after the procedure as well. And then comes the support of some medication part, the activity modifications. I think Namrata will be talking more on that. And there will be a referral for a specialized treatment. Sometimes we do need some medications. So every inch counts. That way, every ounce or every pound counts. So 1 pound of weight loss will almost decrease the 3 to 4 pound of decrease force on the joint. So it is really, really important to decrease weight, even if it is more than 5%. That is also enough for the kind of load reduction on the joints. So the recommended weight loss is just more than 5% of the total body weight of the adults. And this weight loss definitely improves the pain, improves the function, as well as the mobility of the person. Are there any foods that cause inflammation? Yes, Dr. Geeta madam must have already taken a very lucid and exclusive talk on that. And yes, you must have already discussed about this. So nowadays, this concept is coming up on pro-inflammatory foods and anti-inflammatory foods. So calorie restriction, reduced sugar, saturated fat, balanced diet with high fiber, lean protein, and obviously the mindful eating. So these are the exercises. This is not just walking. Patients tell us that we go for a walk, madam, and we do walking a lot, but that is not enough. I think Namrata will address all those exercises, the flexibility, the strengthening, the cardiovascular, and the balance, which all are needed for a patient to have a good muscle strength. The activity modification, many times I find people are ashamed of using a stick. There's a simple kind of technique or device which we advise for the ladies who are having osteoarthritis and walking a waddling gait, but they still prefer to walk like that, but not to use stick. So it's a very simple kind of activity modifications will become very important while managing these osteoarthritis cases. Some use of braces, devices, changing the method and patterns how we do your daily activities. And then comes the pharmacological treatment, analgesics, anti-inflammatory agents, topical as well as oral. A lot of them are available and we do give it very routinely to our patient, but this shouldn't be a very long-term kind of treatment. Then there are some intra-articular injections also at times given when there is a lot of inflammation. Sometimes they do give intra-articular steroid, but generally we do not recommend them to go ahead with that kind of therapies. But now the main thing is what this is metabolic drugs which have come into market, and especially we are talking about this GLP-1RA, and they are really having a really good kind of revolution in the management of osteoarthritis as well. Sorry for this, but this is a bridge between the metabolism and the inflammation. There are two birds with one stone. So dual benefits of semaglutide in obesity as well as osteoarthritis. The step 9 outcomes are already there, and they have shown really fantastic response in their WOMAC, in their pain scores, and in their functioning also. So this was it, and this semaglutide is now even used for the osteoarthritis purpose in the morbid obesity patients. But some subgroup analysis is yet to come, and we really don't know in which patients to be subjected out of these osteoarthritis group, and what degree of obesity, what different stages of obesity and osteoarthritis. So there are things to be covered and we'll be getting to know in near future. So this is how these GLP-1 receptors are there even on the immunological cells. So that's why definite connection between this GLP-1 agonist and the rheumatic conditions or the inflammatory conditions. So immune system, monocytes, macrophage, B cells, T cells, synovial fibroblasts, chondrocytes, and the bone cells, all of them having those receptors. So now this is again paradigm shift in our key recommendations with greater emphasis on self-management, then physical and psychological therapies becoming very important, complementary medicine, less emphasis on pharmacological and surgical treatments for osteoarthritis, and addressing the psychosocial factors becoming very, very important in all those chronic morbid illnesses. So key takeaways, obesity strongly impacts musculoskeletal system. Knee osteoarthritis is the strongest association. Both mechanical and metabolic pathways are involved. Normal BMI, but central obesity, definitely a risk for musculoskeletal complications. Low impact exercises like walking, yoga improves joint function and reduces the inflammation. And having a low target also is sufficient to start with 5 to 10% of body weight. So I think the future targets, we are coming back to the basics. So as we are moving with the advanced pharmacotherapy, at the same time, we are coming back to the basics. Yes, follow a good routine with a good lifestyle, that there should be lifestyle modification in the form of a good diet, nutritious diet, look after your physical strength and the muscles, the exercise part. So all in all, the one thing is sure, to stop inflammation is the key for further success. Thank you very much.
Thank you, madam. From inflammation to metabolic to quality of life was very well expressed. Ma'am, I would like to take some questions if the audience has any questions. She said, take it. Any questions from the audience?
You mentioned about surgeries in osteoarthritis. People are going for very early surgeries. And then what happens is they're not prepared muscle wise. What would you advise? Should they strengthen the muscles first and then?
That's a very, very important question and important thing to address, because I said it's very common now. Just like cataract, people are going for TKRs and THRs, but we have to advise them. If they are overweight, definitely they should reduce the weight before. So it is like a planning of surgery. It is never an emergency kind of surgery. It is always to be planned. And that planning should include the weight management, definitely yes. The muscle strengthening, very, very important. Otherwise, we are looking at people who come with TKR and THR, but still not able to walk, and they are having some problems while walking. So it's very important to address those issues before.
When the patients are coming to us who are getting operated in the next few couple of months, so now there is some new concept that has come. We call it as prehab. So doctors, orthopedicians do refer patients to us 2-3 months prior to their surgery, so that we can plan for them the strengthening, the balance, the flexibility, so that they gain the whatever range of motion is available is maintained, and they are in a good shape to go for TKR and THR. So even the doctors are now, after assessing them, are saying that you go to physical therapist first, get your shape very well toned, and get the flexibility back, get your weight management right, and then only we will operate. Otherwise, now the surgeons are also started refusing doing TKR as and when the patients are walking in.
Ma'am, one question from me, last one. What are the biomarkers we will use to understand the inflammation? You mentioned CRP, ESR. Anything else you would like to highlight there?
Not those leptin and adipokines or TNF alpha. They are not really routinely used in practice as biomarkers to assess the progression of the disease. So we can get the clues from this ESR and C-reactive protein. More studies are with C-reactive protein they are mentioning about. But right now we are not using those biomarkers of these adipokines as in routine practice as such, because they are still in research process and they are not really in the practice as such, and we are not able to correlate. Even that is true for even the inflammatory arthritis also. So whatever antibodies we can get is a one-time kind of investigation, what we suggest at the baseline. But once we know that this is rheumatoid factor positive or CCP positive, further management of the patient will depend upon the clinical evaluation as well as the biomarker, the inflammatory markers in form of ESR and CRP, which will guide us some to the ongoing activity or inflammation. Again, one more thing is very, very important. All those reports are not just the specific for obesity or for arthritis. All of them need to be correlated with the clinical situation, because ESR, CRP are the markers which can come elevated even during infections also. So it is always a clinical correlation of those markers with the clinical thing. So we don't have the absolute markers at present, but maybe in future we can see, because leptin, they are showing a lot of research work on contribution of leptin and association of leptin with the radiological progression and the severity of the disease.
Thank you, madam. Okay, ma'am has a question.
I'm the clinical psychologist who will be presenting my session in the evening. There is a small, Dr. Lagu was referring about a patient who was on a multiple drug prescription.
Right.
And I'm talking about that patient. So this patient has been going from doctor to doctor, you said, and she has about a list of medicines. Now she is into a vicious cycle. Okay. Over here, maybe what my suggestion could be that the patient goes with a new symptom to the new doctor, and then she gets one more medicine added to her prescription. Over here, a good assessment, because there is something she want to talk, and she feels that the medical person will be able to help her, whereas we don't know exactly. She may be having real aches and pains and what all problems, the real medical problems, but beneath that there is definitely some psychological turmoil going on her inside of her, and she is not able to find out what is the exact symptom that she really is presenting to the doctor versus what is it that is creating that symptom. Is there any connection between the internal psyche she has and that presenting symptoms? Many times what happens even in our clinic, patient come from depression, they come for some symptoms. Now it is me and the doctor. Our doctor has a very good listening ear. She's able to pick up. Dr. Deshmukh is has expert in picking up कि क्या होगा नीचे क्या होगा. So sometimes it's a relationship issues, sometimes it is anxiety about unemployment and things like that. So accordingly she would distribute the patient to the specialists which who are there in the clinic. So over here for this patient maybe a good clinical psychological or a psychiatric assessment wherein somebody sits and listens to her what is the priority thing she wants in her life, and because it is not there for her, she's doing this medical. I feel sad for this patient. Okay, thank you. I
Truly
wanted to
agree.
add it.
Truly
Point
agree. But
noted.
only still in our society, still there is a stigma for psychiatrist. I must say that once we utter the word psychiatrist, they
Agree.
really don't
You
want
could
to.
send her to
And
some
so maybe a
psychologist. Yeah.
psychologist is
Yeah.
one. I
Yeah.
think that is a bridge between this patient and the psychiatrist sometimes.
Okay.
That
Yeah,
psychologist is
psychologist
another
can
option
work.
what we suggest them nowadays, that they are not
Yeah.
psychiatrists, but they are just the counselors kind of,
Yeah.
and they will counsel you, and then they will let you know whether you need some medication for your
Yeah.
psychological problem.
Over here I would suggest one more thing. It's not about she going to somebody. It's about what is she trying to say. Somebody just sit to her and listen ki what is it that is
True.
not available to her, and if it becomes available to her, what she will be able to achieve. That is
True.
all I wanted
Very
to say.
So we'll take the
Anyone.
last question from you and then we move on to the next session.
Hi, good morning, ma'am. Very nice session. I just wanted to know, like you mentioned in one of the sentence that women's above 40 who are premenopausal or going towards the menopause, they have a plantar fasciitis issues. So is it sometimes I have seen, like since I'm a yoga practitioner, I see the ladies who are very lean and thin and still having the plantar fasciitis in the morning, above 40, around 40, 45. So, what do you suggest in that case? Like, is it only obesity which is causing this, or there are a number of reasons which and to which doctor they need to go for such things?
These are few gray zones, I'll say. One of that is this low backache, as I said, that patients keep on going to different doctors and they never get solved on that issue at times. Similarly, the heel pain is another thing. The bad postures is one of the thing. Bad use of footwears, the choices of footwears ladies use, they are absolutely bad. At times we have to tell them, we have to look at the feet and tell them, yes, this is wrong and you should change your footwears also. So right from the postures up to the inflammation, anything can be a cause. So one of them, obesity, definitely has this mechanical stress, which is more crucial in having this flattening of the arches, and the local inflammation. Along with that, we do get these heel pains and some other rheumatological disorders as well. The psoriatic arthritis, most of the times they come with heel pain rather than the skin lesions or the arthritis. They do have these enthesitis, and that's why they present with either plantar fasciitis or tendoachelis enthesitis, which is a very common kind of finding with the psoriatic arthritis. So maybe you can have a look at the other causes of the in such lean and thin persons who are not obviously obese.
Ma'am, generally people go to orthopedic
Yeah.
people, and sometimes I feel that is not somewhere solving their problems since going to orthopedic people for a year. So people are confused which doctor to go to.
So, rheumatologists are the one who generally look at all the medical aspects of the conditions which can lead to these heel pain or the regional pain, what we call. But people still prefer to go to an orthopedician since they feel that this is a bone problem or this is a muscle problem. But now it's time that we are all discussing everything together. It comes as a package. So I think physician should be a person who should first decide that this patient, whether this patient needs to go to a specialist of that kind. Because otherwise we are seeing really rampant kind of order or the patients coming up directly to the specialist, not even before screened at the physician level. So I think the physician will be a right person because he has the knowledge and the acumen to tackle all the problems, all the whole body problems together, rather than going directly to a specialist. So once that basic assessment is done and he feels no, this is a regional pain and has to be addressed by a specialist, we do have the rheumatologists who can look after it, and we do have the foot surgeons also now. The orthopedic have got a subspecialty with only who deal only with foot and ankle. So those specialties are also available. I think the first screening should be done at physician level.
Okay, thank you so much.
Can I invite? Okay, we have lack of time, so
Only one small question. With this coming fad of keto diet, you must have heard of, there are flares of rheumatoid arthritis. So, what's your take on that?
Yes, the food padism is really on, and we don't get. I mean, we do get some myths in the arthritis patients about the food, especially the rheumatoid arthritis. What you want, because it is an inflammatory arthritis. So there have been now the foods. Previously we used to counsel that no foods will add to your inflammation and blah blah. But yes, now the concept has changed, and we are saying yes, the foods do have, and the gut does have a role in the inflammatory arthritis. So definitely we need to address upon the diet as well. Sometimes that is very, very important. Yes.
thank you, madam. Thank you. Can I invite Dr. P.K. Joshi, sir, the senior physician amongst us, to felicitate madam? The next session is going to be very interesting, and we've been witness to this interesting session from past 2-3 years, and we look forward for this session. I would like to invite Dr. Namrata Barbare, and you've just heard her talking now. She is going to talk on joint and facial health in obesity, posture, and obesity. It's a big topic, but I think she will do a great justice to it. Dr. Namrata Sidhe Barbare is physiotherapist, and she has done her Masters of Physiotherapy in Orthopedics with sports as an elective in 2011. She is Assistant Professor at DE Society of Brishlal Jindal College of Physiotherapy for 10 years. She's a academician as well as practicing, and she's certified manual therapist by Manual Therapy Foundation India. She's looking after the sports department of the college since 4 years, so she has both practical and academic experience here. She's also a guide for postgraduate and undergraduate students. She's also an examiner for all the institutes of physiotherapy, and she has many publications in national and international journals. So we look forward for your session, Namrata, to make us active and back to this physically great session. Thank you very much.
May I request all the eminent guests to come forward and sit, because I'll be giving some demonstrations here. So may I please request all of you to sit in front. And I'm really grateful to Geeta ma'am for such a wonderful introduction. And I'm also grateful to Deshmukh ma'am and Sir Padke sir, who are my mentors since last 4 or 5 years. And my thinking about the physical therapy as well as health has changed since last 4 or 5 years since I have joined them. So I'll be sharing some of the key concepts and change in paradigm in the physical therapy, since the way it is shifting and our thinking is also shifting. So my topic for today is obesity, and I will be talking about a part of obesity, but I will be talking about much about the interconnections and how if one part is not working well, how it affects the other part. That we'll be seeing in a detail today. So going ahead with the common sites of aches and pains in obesity, we get people who are obese and they come up to us with a lot of neck pain, lot of shoulder pain, lot of thoracic pain, lumbar pain, sometimes hip, knee is very common, and the plantar fasciitis pain, as Payal ma'am mentioned. And since then we are getting these people and we are trying to give them the physical therapy in order to take out their pain. So it was more of a localized approach. And why we have got these pains, aches and pains in obese people is because of, as Dr. Lagu said, that it is lot of pro-inflammatory disease process. So a lot of adipokines are there which are inviting your inflammatory products there and the chemicals there, and they are affecting a lot of cartilage regeneration as well as causing the joint degradation, and the people are coming with lot of aches and pains to us. The next is insulin resistance, which is causing a lot of oxidative stress, and oxidative stress is responsible for the joints to go into early degeneration, and what we call it as a decrease in the muscle mass also of these people. Then increase in the compressive loads, because when we are talking about obesity, it is the body weight, but we are not understanding when there is increase in the body weight, there is, as the Newton's third law says, that when there is a one force which is coming up exactly in the opposite direction, the another force with the equal magnitude is acting on us. So we cannot take we should pay attention to the ground reaction forces, that if 100 kilos man is standing on the ground is also reacting with 100 kgs back on our body, and that is affecting our all weight bearing joints, that is ankle, knee, hip, lumbar spine. And because of all these changes in the kinetic chain, it is going to bound to happen that it is going to be painful for the non-weight bearing joint also, let's say shoulder, thoracic spine and the cervical spine. So that is why all these aches and pains are now all very common. As Dr. Lagu also mentioned, that people with obesity are coming with the fibromyalgia, because all these connections are interlinked, that we will be seeing in detail later in the slides, and I will be giving demonstrations to you. So all these are leading to a lot of problems, and every joint is now vulnerable to get aches and pains whenever it is obesity. Along with obesity, if it is what we call it as a metabolic syndrome, nowadays it is a term which is in commonly used, that people are having dyslipidemia, people are having TSH, T3, T4 levels altered, they are also having insulin resistance, they are also hypertensive. So all that is also altered, sometimes uric acid coming with combination of rheumatoid arthritis, and all that parameters is affecting your musculoskeletal health in a greater way. Then the affected skeletal muscle function, we all know that in obesity it is lot of loss of lean muscle mass. Why that is so? Because there is a change in the distribution of the muscle fibers, lot of your red fibers are changing into the white fibers, the oxidative capacity of the muscles is changing, and because of that we get a lot of skeletal muscle dysfunction, and these people land up with lot of fatigue, and they give up very early during the exercises also. And so that we have to plan their exercise protocols in such a way that we have to have a lot of attention should be given to their rest periods as well. So these are the main causes why people are having aches and pains nowadays, not only in obesity, but whenever the clinical markers are altered. So these are the most commonest problems that we are coming and dealing with. So these are the most commonest postural problems. If you can see, this is a person who has ideal BMI, and these are the spinal curvatures, that they are placed aligned very well. And now the person with overweight and person going on with the obesity. Okay, so what are the changes that we are seeing? It is the somatosensory change. So what I mean by somatosensory change, so when there is increase in the weight, as I said, it causes alteration in posture. So what kind of alteration in postures that we see? These people come to us with a lot of forward head. These people come to us because there is protruding abdomen, there is a lot of heavy breasts that are there, or the heaviness of the chest. They come up with lot of rounded shoulders. They come up because of the protruding abdomen. They come up with lot of anterior pelvic tilt, which stresses the spine. That causes hyperextension at the knees. That also causes decrease in the medial arch of the foot, and which leads to lot of problems, as ma'am said, Pyle ma'am said, plantar fascia. And all these are interlinked because there is a chain of fascia that links everything, and and the chains of neural tissues which link everything. So from our head to toe, everything is linked, ma'am. So for you to for your question, the answer is it can be plantar fasciitis, can be because the cervical fascia is not working well. So you need to see the patient holistically, assess his cervical, thoracic, lumbar spine, hip, knees, whether they are aligned well. And as ma'am said, you are also supposed to assess the footwear that they are using, what is their standing style. Everything comes into the picture when you are getting plantar fasciitis. So it is no more related to obesity, as you rightly mentioned. It is also related to how you position yourself. So all these problems are coming up because of the lot of abnormal posturing, and thanks to our sedentary lifestyle, many people have a desk job, IT professional, they do not know when to stop their work. So they keep on working for 7 to 8 hours, and we are adding up to all these stresses because our body is meant for motion, kinetic control. Our body is not meant to be in a static position, but we are not following that. I feel sometimes Spider-Man is lucky enough because he can change his area of surface, and he can change his weight distributions and can be in a good shape, right? And these people also have lot of somatosensory alterations. What I mean by that, when we are talking about obesity and we are talking about a lot of stress that is coming on the joints, let's say hip, knee, and our plantar fascia and ankle, it causes the receptors, what sensory receptors or mechanoreceptors that we are talking about, attenuation from their side. So there is less sensitivity of these receptors, and because there is a delay from these sensory receptors relaying the information to your somatosensory cortex, the somatosensory cortex now starts more relying, there is a more rely on the vestibular apparatus, on the vision. Okay, so all these other external sensory receptors come into the picture in order to maintain our balance. So if you see, they have a lot of joint position sense alteration, they have lot of balance issues. If you see, they have more of a antero-posterior balance issues are more, and because of that they have a gait alteration. So gait alterations, if the obese patient is walking in your OPD, you will see that his foot is, the medial joint arch is collapsed, and he'll be walking, waddling like this into your OPD, and there will be lot of decrease in the gait speed. The cadence that the number of steps he will be taking will be shorter and smaller. So all that alterations are going on. But what is the link? The link is, so the concept is the regional interdependence. What is regional interdependence is usually first when the people used to come to the physical therapy OPD, shoulder pain hai, so we used to treat only shoulder pain. So but now the concept is changing that even the local regional problem can have a lot of effect, which is on an area which is distant to that particular region. So we have started assessing now cervical spine, thoracic spine, lumbar spine, whether there is some problem in the foot which is giving rise to the shoulder pain. And we are getting very good results when we are starting seeing the person in a holistic way. And the concept of motor learning is also changing. Usually the first motor learning concept that is started is, if the person is not able to eat, you have to train him to how to grasp that particular, take that particular nivala and take it into your mouth. Okay, but now it is how your spine is working that time, how your thoracic spine is working that time, how is shoulder working that time, how is your posture maintained that time. So it is very important. So the concept of motor learning is also changing, and that is the way that exercising is not enough. The form in which you exercise is very, very important. Another thing is that you go to the gym or you follow the exercise regimen for 45 minutes, 1 hour, but in other times, how are you using your body is very, very important. How the way you are sitting, how the way you are working, are you taking breaks in your sedentary lifestyle, what type of footwear you are using, all that matters. So when you are doing exercises, it is the mindfulness or awareness of the exercises, not only exercises, it is how you are using your body throughout your day. That is what matters, and that is what I have understood from my clinical practice. So what are these connections? So this is the area which is very, very interesting that is coming up, and many people have started taking this seriously, is the facial and the neural connection, which connects your entire head to toe. And all these facial and neural connections are now responsible that any particular region, if it is affected, you are supposed to see the interdependence, how it is affecting the other areas in your body, and what are the repercussions of that, and treat the person as a whole, not just the region. So to starting with the facial lines, so these are the some facial lines. So I'll be giving you demonstrations about that the fascia we have learned in our first year dissection, and then we forget about it because then we go into the specializations. But these are the structures which we need to address, and this is how the interdependence goes on, because the fascia has neuronal circuits also, fascia has autonomic receptors also, that we are talking about mind body medicine, and Phadke sir is into it and telling us that we have to have the heart rate variability coming up really well, so that the sympathetic dysfunction goes down and the parasympathetic outflow increases. But the fascia also has a lot of autonomic receptors, and fascia is the connection between our entire body as well as the neuronal structures. So I will just call Maithili to be my model, please, and then I'll demonstrate how these connections, so you will be also surprised how the body works. Yes. Okay, so the first one that we call it as a backline. So the backline starts actually from, just take it under your foot. Yeah. Okay, so all your plantar fascia, right? Then coming to the gastrocnemius muscle, okay, coming to the hamstrings here, going to the sacrotuberous ligament here, all your erectus spinae group, all your neck extensors, and going up to the head. So this is the facial connection. So it consists of lot of muscles and the fascia together, plantar fascia, so your calf muscles, your hamstring muscles, your sarcotuberous ligament, which is responsible for the maintenance of the stability of the SI, then your erectus spinae group, then your cervical extensors, deep cervical extensors, and then coming to the head. So many of the times people come to us with the headaches, and they have gone to multiple doctors and nothing. So some of them are diagnosing them having headaches because of the cervical spine, and many of the times we have found out that we just release their plantar fascia and the headache is gone. And then we started thinking what is the reason, and we have come across these connections, and this is the back facial line, right? So now we will do some exercises for the back facial line. Can you please stand, all of you? So there are some mobility exercises, and we should be doing it every day in our practice. Whenever you are going to the gym, this you can do it as your warm up or cool down sessions. So first we will do some exercises for stretching of the back line. What we are supposed to do is, we are not aiming for here range of motion. We are just aiming that we get a good posture. Okay. So all of you please stand with the shoulder width distance. Yeah. Your toes should be pointing forward. Equal weight bearing on both the feet, right? Take your hands up, right? And slowly, very slowly, you are supposed to feel that your lumbar spine is falling forward, then your thoracic spine, then your cervical spine, and try to go forward from your lumbar spine. Do not bend from your knee. right? Very slowly go down, breathe normally, okay? Do not hold your breath and just go down, go down, go down, how much ever you can reach. It is not necessary to reach the entire to the floor, and hold that. So if you can see, it is almost stretching all your posterior muscle chain, that is your calf, that is your hamstrings, that is your erectus spinae, your cervical spine extensors, all are getting stretched. Please come up. Yeah. Maithili, can you come please? Yeah. So another way of stretching it is Paschimottanasana that you do. So again, so you are maintaining your knee in extension. You will be pulling off your ankles together, hands up, and try to go down. Again, the range is not important. Feeling the stretch is very important. We are not aiming for the range here, and maintaining that. If you can see that the entire stretch is put on the facial line, and this is very, very important in our warm up and cool downs, that we should take care of our fascia and neuronal structures. Thank you. Then if you want to mobilize this, right, what you can do is a sort of calf raises that you can do in sitting also, right? So we will do now 20 calf raises. Huh? Can you please stand? Yeah. Again, maintain a shoulder width distance, right? Toes pointing forward and go up and down. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, right? This exercise you can do in sitting also. When you are sitting in your OPD talking to a patient, you can do it underneath. Keep on doing it every 1-2 hours, no harm in it, right? Then just doing the knee curls, right, like this. Whenever you are standing from your sitting position, you can do this, which is going to activate your hams, and that, I guess, to maintain a facial health, that is enough, right? Then in between, just take a shoulder width distance, point your toes forward and go back from your lumbar spine, and this is going to activate all your erectus spinae, and this is very, very mandatory to break your sedentary positions. And that is what I tell all the physicians, though all the IT professionals, those who are constantly sitting, that keep on changing your positions. For after every half an hour, our body is only able to maintain a position for 20 minutes. After that, the gravity is going to take over and you are going to land up with these postures. And that is the main killer part, not only in obesity, in all of us, that we are not paying attention to our posture at all when we are sitting. So it is a mandatory thing that when you sit constantly, if you have a desk job for 7 to 8 hours, okay, take a break after every half an hour. I am not saying that you stop your work, just get up when you are talking to your patient, write the prescription in standing, give it to him and sit down. That's it. I am not asking you to stop your flow of the meeting. I am not asking you to stop your everything, go take a cup of water. I'm not asking you that, okay? But just standing up also relieves a lot of pressure, and we should do it often, because when we are sitting, the gravity is taking over and we are landing into a lot of curling positions, and then unnecessary we are landing up with the back pain, neck pain, everything. So please take care of your postures. Next thing is that what is mandatory is the footwear, because footwear is going to affect a lot of plantar fascia. So high heels is strict no. When you should wear high heels? When you are just going to sit, you are not going to walk. That time high heels is okay, occasional high heels is okay. But whenever you are feeling some kind of a foot pressure problems, or whenever you are getting the plantar fascia pains, what you should do is get your plantar pressures assessed. Where are you putting a lot of stress? And accordingly, there is a shoe prescription that comes, that for the valgus, or when there is a decrease in the medial arch, these kind of shoes which are required. When there is increased in the medial arch, these kind of shoes are required. And always buy your shoes in the evenings after 7 p.m. because the fullness of the foot is achieved after 7 p.m. So always buy your shoe after 7 p.m., right? If you have any knee problem, right, you need ankle mobility, do not wear sports shoes. Bad idea. When you're going for walking, you have a knee problem, wearing a sports shoes is a bad idea because you're restricting the ankle mobility. The ankle should be free so that the ground reaction forces will be tackled by the ankle more than the knee, right? But if you have an ankle problem, no knee problem, then wear the sports shoes because they need a stability, right? When you're going for a walking on a bare, with a bare feet on a grassland or matti wala sand is good to go. But if you cannot avoid the concrete roads, at least free up your ankle so that you can walk normally and the ground reaction forces will not hit the hip and knee more, right? Then now you can sit now. Thank you. Yeah. Sorry? I will come back to the questions afterwards, yeah? I will just finish my thing first. Then now we are going forward with the superficial front line. Maithili, can you please come again? So now we have finished with the back line, right? Now we will finish with the front line, right? Yes. Hey, pakad. Nahi, hey, pakad. Okay. So the front line goes from the front of the foot as the name suggests, right? Okay. So it is your toe extensors with the tibialis anterior, with the ligamentum patelli, with the quadriceps, right? With the rectus, with the SCM and going back to the head behind. So this is the front line, right? So any alteration in the ankle is going to affect your knee because it has a direct connection from tibialis anterior to your quadriceps. Quadriceps is going to affect your abdominals because they are connected. Abdominals are going to affect your neck because that is also connected, and it is going to affect the extensors of the spine because that is also connected. So this is your superficial front line, right? So maintenance of the health of the superficial front line. So these are the ergonomic exercises that we usually prescribe to our patients when they come to us, maintaining the facial health. 2 mobility, 2 stretching exercises, and the ergonomic workstation exercises are done. So again, we will do this front line exercises. Sit in your chair itself, okay? Feet supported on the floor, right? Without support, just slide forward. You should not take any support, right? And now what we have to do is you have to bend forward with the arms crossed like this, right? And then come up, open yourself, go up and feel the stretch, right? So your entire line is getting stretched, right? Go down again, come up, right? Now this is also there. Then going into the Bhujangasana pose that we also ask the patients to do it. Ardha Bhujangasana is also okay. This can be done by any population. And coming up, this also stretches your entire front line like this, okay? Or going into the Dhanurasana. Maithili, can you please come? Again, the range is not important, but doing all these stretches is very, very important, and the mobility of the fascia is also important. So do not lift it. Just going into this is also enough. I am not asking you to lift all this. Just going in this position and feel the stretch of the quads, feel the stretch of your entire front line is also enough, right? Can you please get up? And now the mobility of the front line, right? So you all are sitting, just extend your toes like this. Just take your ankle up and extend your toes, right? We did previously the heel raises, exactly opposite of that. So you're doing this and extend your toes, dorsiflex your ankle and extend your toes, right? Yeah. So you can do this combo also, heel raise, come up, heel raise, come up, okay? Now you are sitting and just do knee extensions. 1 by alternate legs. 3-4 repetitions. I'm not asking you to do a lot of repetitions also, right? 3-4 repetitions. Yes. Now you are sitting, sit like that, clasp your hands behind, right? And curl up, down. Yes. So that is a lot of work of rectus that you are doing, right? So these are the mobility exercises for the superficial front line, which we can include as a warm up, cool down, and in between your works that you can do when the patients are not around, when you are not working, right? Easily doable. At least 2-3 repetitions will keep you fit. The fitness is this. Of course, the aerobic intensity workout, the weight workout is also important, but maintaining this is very, very important. I have seen many people who are very, very active. I see a lot of athletes who are conditioned already, but still they'll end up with a lot of aches and pains. And the only reason that we have found out that they are not maintaining their form properly when they are lifting weight, when they are running, when they are walking. So that is the most important thing that we should be taking care. I see a lot of amateur shooters. I see a lot of amateur archers who are coming to me. So while studying how they are sitting matters a lot than how they are standing and shooting the arrows. So that is very, very important. So we have to see the person how he is using the body in day-to-day life, right? Now coming to the next line, that we have a lateral line, right? Maithili, with his verse. So the lateral line is extending from, again, on the lateral aspect of the foot, right? You have a lot of everters which take your foot out like this, right? So you have a everters, you have, then the connection goes on to the abductors, right? Then the connection goes on to the glutes. Then yeah, it goes on to the glutes and comes forward to the obliques and goes up here to the sternocleidomastoid. So this is the lateral link, that it goes from outside of the foot to the abductors, to the iliotibial band, to the glutes posteriorly, and then it goes forward into the obliques, and then it goes to the SCM. So this is the lateral line. So when the patient with obesity comes to us, or when the patient with the OA comes to us, we see a lot of them walk like this because of the varus, because they want to decrease the momentum for the abductors and they walk like this. So this we call it as a waddle. So waddling gait is mainly because of the affection of the lateral line that we see. So now we will do again exercises for that lateral line. Yes. So will you please stand, everyone? Just cross your legs, any legs. So we will take one reference leg, right in front of your left. Okay. Take your hands up, bend forward, yeah, and just keep on turning right to left, left to right. You will feel that a lot of stress is coming on the lateral aspect of the foot, right? Especially the thighs. Now change the leg, left in forward position, take it up, go down, and then go forward, backward, go side to side, sorry. Right? Now, going into the Trikonasana pose, again the range is not important. So, you are again stretching the entire facial line here. Trikonasana. Yeah, go down. Yeah, go down. Just bend your leg, this leg.
We don't bend the knee.
Okay. Exactly. Okay. So this is again stretching up of the lateral line. Yeah. Yes. Right. Or standing like this, You can raise your heels if you want. If you don't, that is also okay. Just take it up and go sideways and feel the stretch on the lateral obliques that you are getting, right? So entire lateral line on this side is on the stretch, right? So this is about the stretch exercise. Now the mobility exercise, what you can do is just go with the side kicks. 1, 2, 3. 3 this side. 1, 2, 3. Right? Now going for the back kicks. 1, 2, which will cause a lot of glutes activation here. 4, 5, right? Then going back to the your obliques. For obliques, take your hands up and try to rotate your spine like this. 1, 2, 3, right? Now please sit. Kindly take your seats. Now in the sitting position, what you can do is 1, touch your one elbow to the opposite knee. Right to left, left to right. Yes. So this is activation of the obliques. You do not need any equipment. You do not need mat. Just one chair. You are sitting in the chair. You can do all these exercises in one go, right? Then after that, what you can do is just do the lateral flexion of the neck. Hold it for 30 seconds, right? Relax. Go to the next one. Hold it for 30 seconds and then go. So this is the lateral line. We have learned the stretches and now the mobility exercises. Now going ahead with the spiral line, which is very, very interesting line and we don't use it much, right? So no, stand like. So the spiral line comes from the cervical extensors. It goes to the scapular muscles here, right? It goes to the serratus here. Okay, hold it. Yeah. It goes to the opposite obliques, going down to the leg on the lateral side and ends up in front of the foot. So this is called as your spiral line, and which is very, very important for our rotations to maintain, right? So for this, now to activate your spiral line, Maithili, you are supposed to take, please stand up again. Sorry, I am making you stand and sit a lot. So stretch your arms, right? And you are supposed to go down and touch the opposite foot or toes, right? So this is stretching all your spiral line on both the sides. Very simple exercise. We used to do this as PT exercise in the school, right? But now we know the anatomical connection, why we are supposed to do this. Huh? Now sit in your chair. Clasp your hands behind the head, right? And rotate on either side. So this is all your spiral line that you are taking care of. Yeah, because it is obliques, right? And if you want to mobilize this joint, what you can do is activation of the serratus. So for that, what you need is we don't have a wall here, but imagine that it is a wall, right? And you are pressing against the wall. So that will activate all your serratus here, okay? So imagine that there is a wall in front of you and you are just pressing on that wall and holding the scapula out, right? Now the next thing what we need is hold your hands like this in the seating position itself, right? And now just take your scapular blades behind. 1, 2, 3, 4, right? So this will also correct your posture, because when we tend to sit for a longer period of time, we are like this. Now we are correcting it, keeping it like this and go like this. Again, no equipment needed. You can do it wherever you are sitting, even when you are traveling, right? And then for the obliques, again we have done this. So we have this exercise for the obliques which are coming up. So now the stretches for the spiral line and the mobility exercises we are done. Now we will go to something called as deep front line. So this is going from stand facing that side. Yeah. So this is going from behind the behind the medial malleolus, that is your tibialis posterior, going up to the popliteus here. Just hold here. Huh? Yeah, yeah. Going to the popliteus here. Okay. From the popliteus, it is coming forward and going to the adductor group, going to the iliopsoas femoral triangle here, going to the obliques, right? Here it also has some connections to your pelvic floor muscles, levator ani, right? Also some connections to the pericardium, also some connections to the parietal pleura of the lung, right? Going up with the obliques, intercostal muscles here, yeah, and going up to the neck, to the deep cervical flexors, what we call it as longus colli, and it ends there. So this is the deep front line starting from the posterior aspect, that is tibialis posterior, coming forward, crosses the knee, comes forward, goes to the adductor compartment, goes to the femoral triangle, some fibers goes to pericardium, parietal pleura, some fibers go to the levator ani, then the intercostal spaces, and then coming up here. So now we are also seeing a lot of patients who are asthmatic patients who are having a lot of COPD conditions coming to us with a postural issues and a lot of aches and pains in the musculoskeletal system, and when we give them facial releases, the pain eases off. The reason is these connections, right? So now to work out with this line, what we are supposed to do, we will first do the stretches, right? So what you are supposed to do is sit with the shoulder width distance between the feet, right? Take 1 foot behind, okay, 1 foot behind, and feel the stretch on the iliopsoas, right? So if you are sitting, huh, so if you are sitting like this, right, take your 1 foot out like this, huh? So you are stretching all your iliopsoas and as well as the adductors, because the foot is abducted, and feel the stretch, right? With the other leg as well. Right? Now, for the intercostal muscles, what you are supposed to do is hold just at the lower rib cage, right? Breathe in, and you are supposed to feel the fullness under your palms, right? Just try to inflate that lower rib cage. Relax. Breathe in, breathe out. Breathe in, breathe out. Now, just below your clavicles, hold it, right? Feel the fullness beneath your palms, right? Breathe in, breathe out. Breathe in, breathe out, right? Now, when you are doing this, sit straight without any support, and the most neglected muscle, pelvic floor, in men as well as in women, right? And which is very, very important when we are talking about the exercises. So what you are supposed to do is the area in between your thighs, okay, as if you want to go and pee, but you cannot go. So you will hold your urine, right? So that is the way that you are supposed to do. Try to hold the urine, okay? So you have to take up the area in between your ischial tuberosities up and feel the contraction. Hold it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Relax. Again, hold it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Relax. So this is the sustained contraction. Now you can do the quick flicks. Hold, relax. Hold, relax. Hold, relax. So when you do this, automatically it also contracts your abdomen. It also contracts the spinal extensors. So it is a co-contraction that is going on, and that gives a lot of stability, and no one even understands that you are doing some exercises which is easily doable by you wherever you are, right? So this is about your deep front line. Then we'll go to the next lines. Functional lines, which are very important when we are seeing the athletes, right? So these are the lines that connects one right side to left, left to right, right? Stand facing that. So this is the first functional line which connects the shoulder on the right side to the glutes on the opposite side, comes forward and connects to the lateral part of the quadriceps. This is one functional line which is responsible for you to do a lot of rotational activities or a lot of bending activities, right? So this is one functional line. Next functional line is in front, that starts from the pectorals, the rectus sheath, and then it goes to the opposite side adductors, right? So your pectorals, so if you can see, the one side shoulder is connected to the opposite side lower limb, and that is the functional linkage, right? So pectorals going to the rectus and coming to the other adductor group, and that is the connection. And then the last line that we call it as the ipsilateral line, it starts from the, again, latissimus dorsi, goes to the obliques here and goes to the sartorius. So this is the ipsilateral line which is responsible to carry out these and these activities, to carry forward, right? So all these are the functional and the functional lines, anterior, posterior, and the ipsilateral line. And for the exercises, to do these exercises, what we are supposed to do is take your hands up, right? Sit without support and look straight, right? Shoulder width distance between your feet, the toes pointing forwards, and the hands goes down like this. 1, 2, right? 3. Then going up and turning on either sides. 2, which takes care of all your functional lines. And again, if you are doing the oblique crunches, it will also take care of the sartorius and the spiral lines. Okay, so these are the warm up that you can do with all your fitness regime. Warm up and cool down must, because all these connections are very, very important, and we are seeing a lot of patients with the interdependence. So what is the function of this fascia? It definitely it connects the entire body and all the body parts with each other. We have seen that it is abdominal viscera, the pleura, the pericardium is also connected with all this, but it also has a lot of neural circuits, autonomic circuits, right? It is responsible for the force transmission. If one area is not moving well, it is going to affect the other area. So like I said that for the plantar fasciitis, it can be the neck issue that can lead to plantar fasciitis, right? And the function as a joint position. So many of the times these people will land up with lot of balance issues, not only in obesity, but wherever the facial dysfunctions are there, wherever the clinical markers are affected, you will see that those people will be having lot of balance issues, and we should take care of that, because all these are interconnected, right? And when we are doing this, when we are training this, it is not just one principle that should be addressed. Oh, obesity, so let's do just aerobic activities. No, it is not that. It is aerobic activities, it is the strength, it is the flexibility, which is very, very important. So all together, that the strength, flexibility, speed, and your endurance. It is not only just the cardiac endurance that we are talking about. I'm also talking about the muscular endurance. And you should be taking care of all this together and preventing the overtraining, which is very, very important. That the patient should not develop any soreness after your treatment. That means you have achieved your goal. If after going to the gym, you have lifted some weights and that is creating a lot of soreness in your body, that means you have done something wrong. That is a clinical sign that you should consider. Soreness should not develop until and unless any myofascial release or anything that has been done to you. Lifting weights should not develop a soreness. So please take care when you are also doing your gym activities. It should be, exercise is a pleasant activity. It should freshen you up. You should not go out with the gym, this is paining, this is not, I will not go to the gym next 2 days because I have worked out very rigorously the previous day. No, this should not be there. So it should be a very pleasant activity and you should be aware of your own body. So why all these connections and why we are discussing this? Because at the end of the day, we should be all aware of our body parts, and even if there is subtle changes that are going on, you should be able to tell your doctor, or you should be acknowledge yourself first that this is going wrong and I need to correct that, right? So I have some case scenarios here. These are not obese patients, but I thought that this will give us some idea about how the interconnections go on. So this is a 37 years old male and he's a badminton coach and a shooter. And he came to us with a complaint that he has a back pain, and especially a forward balance he was losing when he was into the shooting position, and right knee instability, and all these problems were there since 7 to 8 years, and it is a gradual onset pain and midline pain. When we saw, he has a reduced sensation over the dermatomes and the lot of postural abnormalities. If you can see, he has a limb length discrepancy on the right side. He has a lot of scoliotic curvatures in the lumbar lumbar cervicothoracic region. The scapula was not positioned well. He has dyslipidemia along with that, borderline HbA1c positive. He also had a lot of tightnesses, that is iliopsoas piriformis, posterior knee capsule because of the limb length discrepancy and TA tightness, lumbopelvic rhythm altered. So all these dysfunctions, and the patient came to us that I cannot manage when I lunge into that position, when I want to shoot. That is a problem that he came to us. And then when we saw him, we came to this assessment, and also when we saw his x-ray, he had a spina bifida at L4 L5, and all the static and dynamic balances were altered, and no one had given him any shoe raise or anything, was not managed at all. So what we did is correction of the limb length, and now we are managing him with the mobilization because he has lot of sacral rotations, lot of SI joint problems, and we are managing him with lot of stretching, strengthening, balance training, and he is doing treadmill walking and cycling. So all the principles, we are doing it here for him. The next case is 27-year-old male recreational footballer, and he came up with a complaint that he has a right knee pain after the activity, and he also feels the stiffness in the knee and reduced mobility. He feels his hips are stiff. Surgical history, right ACL reconstruction and medial meniscus 6 years back. And posture, right from the shoulder, everything was altered. Shoulder elevated, medial arch was reduced, right knee was flexed, bilateral everted foot and tibial extorsions. Tightness, he had a lot of stiffness at the hip, so all the DLF, all the hip muscles were tight. Balance, dynamic balance was altered, and girth on the thigh, even though he was a footballer, very well conditioned, but the firing of the hamstring and quadriceps was not up to the mark. So that is what I'm trying to stress here is it is not important how much the strength you have. Of course, the strength is important, but the sequencing in the muscle is very, very important. Whether the hamstring and quadriceps, for example, are firing in a synchronous way or no. Whether when one is activating, the other is doing the job of stability. Is there yes or no for that? So if you are able to assess that, that solves a lot of problem, and the proprioception was impaired on that side. So management is we incorporated all the stretching, strengthening, balance and proprioceptive, and we are getting very good results with this fellow. Case 3 is again a very, very interesting case. Came to us, 52-year-old male came to us with a desk job. He had complaint, primary complaint was shoulder pain and a stiffness in the shoulder, restricted. So appeared to us with a frozen shoulder, secondary to rotator cuff problem. But he also mentioned later on that he's suffering with low back pain and stiffness in the thoracic spine. So we started assessing him, then we assessed his posture, then we found out that on X-ray entire spine was degenerated. Early spine, we are still ruling out what is the cause of the early spine degeneration, right? Then there was anterosuperior humeral head translation with the increased kyphosis, increased lumbar lordosis, and the structural scoliosis on the left side, right lumbar, left scapula in elevation, internal rotation and protraction. So all these were the mal problems that the patient came in. So when we thought of thinking about it, it is going beyond the shoulder now, right? The range of motion, cervical spine, thoracic spine, lumbar spine, all are restricted, and a lot of muscles weakness in the scapular muscles, in the core muscles, quadratus lumborum was weak. Tightness is everywhere, it was tight, especially the cervicothoracic region, all was tight. So we have started with the shoulder mobilization, scapular sets for him, posterior pelvic tilt, and still ruling out the reasons for the why there is so much of early degeneration. Almost you can see that the spinal, the vertebrae are fused together. So first we thought of he is suffering with AS, but all the markers came negative. So now we are trying to rule out what it is. And all these patients have the borderline HbA1c positive, dyslipidemia and altered T3, T4 levels, right? And I would like to show one experience of our patient. The patient was referred to us by Dr. Lagu, and can you please click on the link? Net on hai na? Net lagel mala. So the patient came to us. She is a middle-aged lady who had rheumatoid arthritis, and it diagnosed in 2020 after COVID, and she is a golf player, recreational golf player. Earlier she was only on to the medicines, and then we started her seeing, assessing her, and we also incorporated a lot of relaxation exercises, what Fadke sir has taught us about the breathing exercise with 90-90 position, and all that we are doing, and all the principles that we have given to her. She has just shared her experience with our team.
Good morning, everyone. I wanted to share my journey with you all. I was detected with RA during COVID times, and initially, for 5 years, there was no minimal pain, and I was taking the medication regularly as recommended by my rheumatologist. I used to also do yoga, walking, and outdoor activities. It never hampered me much. But since last 1 year, since 2025, the pain started increasing. There was overall body stiffness, shoulder pain, and my small joint stiffness. So slowly this started affecting my day-to-day activities. I had no strength. Sometimes even picking a bag was difficult. Opening jars were difficult. So it was getting very, very discomforting. And I used to be also tired by the end of the day. So whenever I exercised, I used to experience pain. So either I would stop exercising, or there used to be a lot of breaks, and always I had to resort to painkillers for relief. There was always a doubt that whether this pain was it because of exercise soreness related pain or was it an RA pain? I was not able to distinguish between the two. So I spoke to my rheumatologist and then she recommended me to meet Dr. Namrata ma'am and get her consultation. So when I met Dr. Namrata, our focus was on strength. How do I gain my strength, better endurance, and overall energy level should be high for an active lifestyle. At the same time, independently, I kept a strong follow up with my rheumatologist, also focused on my diet and my overall mental wellness. So, as I understand, Dr. Namrata ma'am thoroughly examined me for my strength, flexibility, for the endurance and balance. And based on her assessment, she drafted a customized exercise plan for me. This plan was closely monitored by her assistants. Periodically, they would take feedback from me regarding my fatigue levels, energy levels, and overall pain. And based on these, they would periodically alter my plans. So they would alter the plans would be of the nature, for example, certain exercises they increase the weights or they introduced weights for those exercises. Some exercises were discontinued because they were, there was pain while doing the exercise. Exercises like treadmill and cycling, the duration was gradually increased. Like we started with 8 minutes and then gradually we went up to 25 minutes and it's improving. Most important were two things that helped me a lot is wherever required, manual therapy was given, which gave a lot of relief and also freed up the muscles to do more exercises. The relaxation technique also helped a lot in terms of cool down and recovery. At the same time, they observed my recovery pattern and at times encouraged me to take breaks. And that recovery is actually helping me build the strength. One more important thing was they suggested variations in various exercises to reduce the stress on the small joints, so which the exercise could be completed without creating any pain. So overall, this protocol has helped me a lot to come a long way, and my overall energy levels are up. My fatigue levels are very, very low. I'm very active throughout the day. The dependency on painkillers I have drastically reduced, virtually nil. All the markers are in range. And throughout this entire process, I have a better understanding of my body. So I can continue my journey with them pain-free.
So she is our patient, and she is coming to us with since 3 months, and we are following it up with her. And one more important thing is we should avoid overtraining. Overtraining actually deteriorates the condition in your gym, even though you do not have any aches and pains, but still overtraining. I have seen a lot of people who are very active, doing this, that, everything, but is your body resting enough? That is also very, very important. So taking breaks whenever you need, stop whenever you require is very, very important, and that is what makes us feel good from inside. Thank you.
Thank you, Namrata. We'll take the questions a little later because Sir has a flight to take, and so we'll take his session first. It's a 30-minute session, and we'll take the questions later on. So now I invite the next speaker, Dr. Sachin Mittal, sir, to talk about, and it's very connected, the topic, protecting muscles while losing weight. So sir's held the position of fellow at APPES, School Bali, Indonesia, after which he joined Department of Endocrinology, Tamil Nadu Medical College, Nayar Hospital, Mumbai. He was fellow at ISPAT in July 2013. He was also a fellow at ESPE, Georgia. His areas of expertise include diabetes, obesity, thyroid, all the metabolic areas, and hormonal imbalance. He is endocrinologist from Chandigarh. Over to you, sir.
I'm Dr. Sachin Mittal. I'm basically belonging to Chandigarh, half Maharashtrian, you can say, not because of any birth woe, but because I trained in Bombay. माझी DM बॉम्बेला नायर हॉस्पिटल मुंबईला केली होती. नाव आत्ता मी चंदीगडला आहे. चंदीगडला मी एंडोक्रिनॉलॉजिस्ट आहे. वैशाली मॅडम इज माय सीनियर फ्रॉम नायर डेज and super senior, very, very respected senior. First of all, many thanks to her for the invite, and she has been kind enough to come to Chandigarh also a couple of times for our annual meeting. And whenever Vaishali madam calls, this is like, it's not an invitation, it is a likha hua word ki I have to come, right? So, and the work she's doing in mind body medicine is amazing. Matlab, I don't think anybody in the country is doing a better job in terms of mind body medicine, in terms of connecting the dots when it comes to, correlation between obesity, its relation to mild health and all. Sorry, I'll just put the phones on silent so that nobody gets disturbed. So I'm going to be talking about obesity and its connection with the muscles and its connection with the, how we can protect our muscles, right? While talking about obesity treatment and all. So are you worried about muscle loss when patients lose weight? Are you worried about muscle loss? Yes. Why are you worried about muscle loss? Strength is decreased, right? Why are you so much worried now? You were not worried 10 years back, you were not worried 5 years back. Was the strength not getting decreased? They were doing household work, so this is, yes. So nowadays, the biggest focus, why it is so माझी DM 2009 to 2012 पर्यंत होती. That time there was no topic in any conference about muscle loss, right? Only since last 3 to 4 years there has been conference, every conference. Why? Because earlier what we used to have options for treatment of weight loss was very little. तो तुम्ही फक्त हे डाएट फॉलो करा, तुम्ही फक्त हे एक्सरसाइज करा, 3 महिन्यानंतर आपण परत बघूया. That is what we used to say, right? Now at maximum we used to have a molecule called as orlistat, right? And we used to use orlistat. It used to work in 20-30% of patients, and that too very minimal, right? It did not used to work great anyways, right? And two extremes you used to say, get a surgery done. सर्जरी का नाम सुनते आधे पेशेंट भाग जाते थे, आधे पेशेंट सोचते थे बाद में करेंगे, right? So now we have how much was the amount of weight loss? About 30%, 25% of the body weight used to get lost. Now we have anti-obesity medications. Anti-obesity medications in last 3-4 years have led to a huge amount of weight loss. What is the amount of weight loss that's having with anti-obesity medications? Anybody?
20 to 30%.
20 to, not 30%, ma'am. Current available anti-obesity medications with 1.5 year of therapy, 72 weeks of therapy. With semaglutide, the weight loss is up to 16 to 18%. With tirzepatide, it's up to 21-22%. With the forthcoming analogs, like triple analogs, and also there are probably it's going to reach 25% and all. With gastric bypass, how much is the amount of weight loss? You can get 30-35%, right? So the earlier procedures for weight loss, that is endoscopic procedures and a lot of other procedures for weight loss, they used to 15, 18, 20% weight loss. So all of those have gone out of business, right? Those balloons and endoscopics and all those have gone out of business. What is now in business is either these anti-obesity medications or bariatric surgery to the extent of gastric bypass where you need that amount of weight loss, right? Right? And now with muscle loss, which is actually approaching the efficacy of a surgery, comes the scrutiny. क्या loss हो रहा है? Muscle loss, weight loss हो रहा है कि muscle loss भी हो रहा है, right? That scrutiny is what is leading to question as to how much muscle are we losing. Now I ask you a question. Suppose you go on a diet, your patient goes on a diet and patient loses a lot of weight. What will the patient lose? Fat loss or muscle loss? Fat loss or muscle loss? Both or mainly fat loss? Tell me one.
Mainly fat loss, and along with that a little bit of muscle mass.
So that is important point to remember. Any method of using weight loss, bariatric surgery, diet, anything will cause weight loss with both fat as well as muscle, the muscle loss will be there, but it is less compared to the amount of fat which is lost. Question is not whether the muscle is being lost or not. Weight is being lost. Question is whether it is proportionate or disproportionate. That is the question that we need to answer, whether it is clinically relevant or not. Like we had a beautiful talk on the physiotherapy aspect, the stretching and all those things, right? Muscle loss, that is absolute volume of lean mass that we are doing by doing a DEXA scan and other thing, is not equivalent to muscle function. Muscle function vegda hai. Muscle function basically is, how much is your strength, how much you can walk, how much is leading to frailty, how much it is leading to risk of falls, how much it is leading to risk of fractures. That's muscle function. None of the studies which are actually doing currently the muscle, the measurements, they are not measuring muscle function, they are measuring lean body mass. Lean body mass includes a lot of things apart from fat mass, right? So that lot of things get included as a part of that, and that is why it's important for us to remember that. Can I have a slide change? Yes. So I think this is the figures you can see about the efficacy with surgery. This pointer, okay. You can see from here, on the top, on this side you see the amount of body weight change. On this side you see the amount of lean body mass percentage change. Right? Lean body mass percentage is not muscle mass only. There are a lot of other things into that also, right? But then you see the different options. You see semaglutide, you see retatrutide, you see tirzepatide. These are the most common anti-obesity medications. Then you see the bariatric surgery. So, and you see the muscle loss, the lean body mass loss. So there is that amount of loss which is happening with any therapy. चाहे आप 2 लाख का डाइट प्लान लेके करो, चाहे आप कैसे भी करो, अगर आपको मसल लॉस प्रिजर्व करना है, you have to exercise. There is no other shortcut, right? So in fact, the studies have clearly shown, this is a beautiful study which clearly shows that the amount of weight loss on pharmacological therapy is equivalent, lean body mass is equivalent to what you see with the hypocaloric diet. It's a publication by Prado et al. 2 years back in the reputed journal Circulation. So lean mass loss can vary 15% से लेके 40% तक different studies में हुआ है. How much it is based on dose, drug, duration, number of factors, number of variables which are there. So the analytic estimates are similar. 25% of roughly the total weight loss is lean body mass loss. Okay, so that's something to be remembered. So that's the question is proportionate or disproportionate, clinically meaningful or not, and modifiable or not. So when you talk of modifiable, which means that what are the modifiable factors, or what are the factors which actually lead to lean body mass loss, right? So aging, of course, we know that sarcopenia is a process over a period of time. Pre-existing low muscle mass, which is already a factor, right? Presence of comorbidities, like now, the place where I work, Chandigarh, India is a diabetes capital of the world, everybody knows, right? And Chandigarh is the obesity capital of India. I can say that because the ICMR data says that the amount of obesity in Chandigarh is huge, right? And it's predominantly because of the diet factor. If you all happen to be in Chandigarh, I think the first thing you'll like to try is an aloo ka paratha with butter, right? That's a staple breakfast for everybody in Chandigarh, right? And you can see that that's driving the obesity epidemic like anything, right? So, presence of comorbidities, if there is a diabetes, if there is a vitamin D deficiency, if there is a protein which is intake which is less, it is basically going to hasten the muscle loss process, right? History of weight recycling, yo. You see a lot of patients, वो डाइटिशियन के पास मैं गई थी, उससे 20 किलो लूज हुआ, जैसे ही छोड़ा मैंने उतना बढ़ गया मेरा, 4 किलो एक्स्ट्रा बढ़ गया मेरा. Have you heard these stories? Anybody in this room haven't heard these stories? Everybody has heard that story, right? Because, and the more these patients go on yo-yo, the more is their weight loss, के साथ-साथ fat loss, muscle loss. Because, most of these people, they are losing weight not by getting into a good fitness regime. They're losing weight because they have a target to meet. 3 महीने में शादी है भाई की, 3 महीने में photo अच्छा आना चाहिए. Like that kind of a target many people have, or sometimes the health issues, they're becoming like that, right? physical inactivity is one of the biggest factors which actually leads to lean body mass loss and muscle loss, right? So inadequate protein intake is another one of the big factors. I've highlighted these two specifically because these two are the most modifiable factors which are there in patients and our hand to help our patient protect the muscles, right? So currently the limitation is we are measuring by DEXA, which is measuring lean mass, which is not same as muscle mass, which is not same as muscle function, but that is what we currently have, right? So, so why does it happen? Mostly calorie deficit is what is leading it. And calorie deficit जब होता है, जब थोड़ा सा खाते हैं हम, तो what do we tend to eat? Do you like to eat protein? आपका जब कुछ खाने का मन नहीं करता तो ये नहीं बोलते कि मेरे को सोया दे दो, कोई नहीं बोलता, राइट? आप बोलोगे पोहा दे दो थोड़ा सा, थोड़ी सी कटिंग चाय दे दो साथ में, राइट? बराबर ना? So our basic tendencies are like that, right? I remember a tweet by Elon Musk when he took over Twitter, and he said that now this platform is a free platform where you can do everything, where you can say everything. Then somebody asked, what do you mean by everything? He said, carbs are the simple joy of life. Simple and inexpensive joy of life. All of us, whether we realize it or not realize it, we tend to feel a little bit happy, right? सिर्फ protein खा के किसने try करा है कभी? Anybody's tried it? I have tried it. I had a lot of challenge in terms of weight loss. I lost about 10 kilos of weight 2.5 years back. My weight loss journey started when I went to this, have you heard of this thing called Vipassana? This Vipassana meditation. I went for Vipassana meditation, which is 10 days silent meditation. They do give you 2 meals a day, one at 6 in the morning, other at 11 in the morning, and then next meal, Udaya Sakali 6 vasta, right? That's how intermittent fasting is there. So I lost in 10 days 3.5 kg, right? So, and afterwards when I came back, I tend to put on weight, but then I tried protein. After 3-4 days, I felt like bhad mein gaya weight loss. I don't want to live this life of having only anda in the morning, soybean in the night, and paneer at night. I don't want to live that life, right? So it's not easy, but it can be done in a graduated, slow fashion, right? Our bodies, our GI system is not tuned to having too much protein because we have not been eating that since childhood. That is why there is always a possibility that you can develop nausea, acidity, gastric upset, constipation, all these kinds of side effects. So slow, gradual increase is important. किताब में लिखा है 1.5 gram per kilo protein per day. How much is the patient? How much you and me are eating every day in terms of protein? Any guesses? How much you and me protein are we eating every day? Not even 0.5 gram, madam. Not even 0.5 gram. 35 grams sometimes it becomes difficult for us on a daily consumption to it. You know, you try putting around whatever content you had, just put the content on ChatGPT and say that this is all I had in the day. Tell me how much was the protein intake in my day as per NIN guidelines. ChatGPT will give you exact answer how many gram of protein you ate in a day, and you will be shocked. You will think that I'm going to have the biggest sarcopenia in the world 30 years down the line, right? So, you know, try doing these exercises. It's fun sometimes, right? So, there is some good news too. Muscle loss के साथ साथ जो proportion of relative lean body mass to relative body mass is not changed too much. If you see the down there is a loss of lean body mass which is there, but the proportion compared to the fat mass loss is not down. Actually, the relative proportion becomes better. So if next time a patient asks you, I don't want to go on this Ozempic, Mounjaro, semaglutide, all of these things because of muscle loss happening, I only want to try diet. Tell him or her that, you know, any form of weight loss, unless and until it is actively, and unless and until there are active measures to counteract the muscle loss, will lead to muscle loss. The relative amount of muscle loss will be less than the relative amount of fat mass. So net and net, you will be positive only, right? That is something which is very, very important for us to remember that, right? And there are some actually now studies which are coming that there are some beneficial effects, molecular effects on muscle quality and function because of some changes in inflammatory markers which they have seen. And actually, the post hoc analysis of number of studies where MRIs have been done have shown that actually there is a favorable effect on fat inside the muscle. That is, not only one of the reasons why you see the lower muscle mass is because the intramyocellular fat also is going down. So when you're measuring inside on your MRI studies and everything, you find that the total muscle mass volume is going down, but the fat inside the muscle is going down, which actually is good for the muscle in the long run, right? The biggest question that we have is, are these molecules having any kind of direct side effect on the muscle, any direct myopathic effects? That's, as of now, is showing there is no such thing like this. On the other hand, preclinical mechanistic studies are showing that the muscle glucose uptake is actually improved with GLP-1 RAs, and the microvascular perfusion is actually improved with GLP-1 RAs, which actually theoretically should be protective, right? So what can you do about it? Protein. Again, we come back to the same thing. Protein, 1.2 to 1.6 gram per kg per day is what, say some guidelines say 1.5, 1.6 gram protein per day, but easier said than done. Try incorporating simple means of putting protein into patients' diet. Many people are not averse to taking protein powders, right? Many people are not averse. Tell them, why don't you try our good old sattu? Right? Why don't you try our good old sattu? Why don't you mix some chana ka atta in your chapati? Right? Simple solutions. There are some protein powders which can added as a part of atta while preparing the dough. So why don't you try that? Just encourage our patients some natural methods, right? Just tell our patients, tomorrow you are having a serving of paneer or a soya. Why don't you decrease your chapati by half and take one more serving extra of of your protein containing thing. But always remember, fiber first, right? Tell your patients fiber first, because only protein will make his or her go for a toss. Then that patient is gone. He'll not try it again. So fiber first, because that will take care of the digestive part in a much better manner, right? Resistance training. This is very, very important. So resistance training is extremely helpful in taking care of sarcopenia, right? By the way, what is sarcopenia? What is the definition of sarcopenia? The topic is sarcopenia, right? What is sarcopenia? Muscle loss, right? Muscle loss, right? So it's a Greek word which basically is a combination of two words. Sarco means flesh, penia means absence. मतलब flesh कम होता रहता है, right? So we think it's a muscle loss. Actually, the definition is not this. The definition is loss of muscle mass was the original definition. Now the definition is loss of muscle mass as well as function. Right? So function is, you can measure by hand grip strength. You can measure by things like how much, sit to stand, over a 10 meter walk, how much time the patient takes. Simple tests, calf measurements. All these things are a measure of muscle function. So sarcopenia by definition is muscle mass as well as function both, right? Resistance training is extremely helpful. It protects against sarcopenia. It's good for the bones as well, especially in females, postmenopausal females. It has been shown to protective against osteoporosis as well. So resistance training is something, the more you talk about, the better it is. It is good for insulin resistance, helps in diabetes as well, right? So lifestyle interventions, we've talked. Calcium, vitamin D, if it is not adequate, make sure that it is adequate. And can we decouple the fat mass loss from the muscle loss? मतलब कोई ऐसा दवाई आ जाए जिससे मसल मेरा बढ़ जाए, बैठे बैठे मुझे चलना ना पड़े, और फैट मेरा कम हो जाए. Good idea or not good idea? Good idea, na? So a lot of companies are working on that. So there are some, activin inhibitors. There are some, myostatin inhibitors, which are actually called bimagrumab, etc., which are now being tried. They are doing it as a combination with semaglutide, combination with tirzepatide. And what they have seen is that the fat mass loss is more, the muscle mass loss is almost nil. So आज की डेट में हम यूज कर रहे हैं ओजेम्पिक मंजारो, कल की डेट में ये दे विल ऑल्सो इनके ऊपर पिगी बैक होकर अनदर मॉलिक्यूल होगा जो फैट मास करेगा लूज, लेकिन मसल मास लूज नहीं करेगा. As of now, it's very early, theoretical, but there are some trials which have started happening. There are some side effects also, which some of these molecules are having, like say GI side effects, muscle spasm, etc. And only time will tell whether these are safe, efficacious over a period of time. Another of this trial is going on called as Courage trial, which is basically talking about semaglutide with another of this myostatin inhibitor, which is basically looking at the same stuff. So another category of molecules which is being tried is called as selective androgen receptor modulators, right? Many of you would have used an older version called decadurabolin. Many people used it, right? So newer molecules being tried alongside this to show whether the muscle mass loss can be decreased while the fat mass loss continues with GLP-1RA. So we as of now don't know which patient will lose fat more, which patient will lose muscle mass loss, right? You would have seen some patients on GLP-1RA who do not lose muscle, do not lose weight. Have you seen some patients? Anybody? Have you seen some patients? Yes, na? We all know there are patients who do not lose the weight, but they don't lose the weight, right? And we also know some patients who lose a lot of muscle, but they don't lose too much of fat. So there are probably some phenotypic, genotypic variations. We don't really know. I think it's just down to different GLP receptors in different patient. So key takeaways: muscle mass lose is a reality. The question is not whether it happens or not. The question is it proportionate or disproportionate? And what can we do about it? Is it affecting the muscle function, not only the muscle volume? That's important point to be remembered. And what can we do to prevent it? So muscle training, resistance training, as well as high protein intake. An important thing to remember is that, don't shy away from telling this patient that the muscle loss will happening. Tell the patient very, very frankly, every weight loss measure will lead to muscle loss unless and until you are the person who is in the driver's seat taking care of not happening it, right? So, and begin from the beginning itself, from the treatment initiation, not while the things are started happening. And that is what will lead to much better outcomes in the long run. So I would like to stop here and thank you all of you for your kind listening. We'll be happy to take all the questions. Thank you. Thank you so much. And it's always such a pleasure coming back to Maharashtra. I always feel I've come back home. I get the lovely poha and a cutting chai in the morning. It's always nice. And whenever I have time, I can tell you there is a very small Malwani joint near airport. And sometimes I, just spend 15 minutes there and have a pomfret there before taking my flight. It's always such a pleasure coming to Maharashtra always. Thank you. Thank you.
Thank you, sir. We would like to take questions. Can you be seated here, sir? I would like to invite Namrata also here. So, interesting two presentations back to back we had. Namrata, it was excellent the way you showed us the physical strength, the stretch we are still feeling, and we feel so fresh about it. Thank you, sir. I think you made the presentation more complete by telling us that how the muscle and fat can be looked at while we are losing weight. So now we take the question. Can you have a seat, sir? We take questions for them now. You had a question, yeah. Fine.
Thank you. Hello. Yeah, thank you so much, Namrata ma'am and sir. It was really very informative. And the best thing I liked is there are very clear-cut, actionable things given to us to take back home. Like sir said that resistance training and protein intake. That's what he has highlighted, two arrows. For in general, we need to focus on. I have question for Namrata ma'am. A lot of questions, ma'am. So you have shown us certain exercises like is there any core engagement needs to be done while doing, or like can you just give some do's and don'ts while doing all those
Yes.
fascia?
So when we are talking about core, actually, when we talk about core, it has been in the literature a lot of mention about the lumbar spine core. So I would like to clear that myth that every joint has a core. All the muscles which are closer to the joint are the stabilizers, and all the muscles which are away from the joint axis are the mobilizers. So whenever you are moving a joint, you have to take care of those stabilizers and mobilizers. So yes, core engagement is very, very important. And when we are talking about, let's say I'm doing a shoulder joint mobilization or activity, so that time, how am I standing? How am I sitting while doing that exercise? How my spinal alignment is very important. So all will be taken care by the core muscles. So core engagement is very important in all the exercises that we do.
Okay, thank you so much. You have also mentioned about the soreness that if you are doing the exercise, and that is a very, very important thing or a different thing I have heard today, that because in general the common public generally says कि if I'm going to the gym, you are supposed to get a soreness because muscle tear will be happen and you will feel that soreness. And even the gym instructors always says कि muscle tear होना चाहिए, so that that last rep has to be in such a way that you need to feel that. So I really want to understand that what you said, that there should not be a soreness, and if there is a soreness, then it's not a good act.
Yes. The recent concept is, ma'am, now the nociceptors, that is the pain producing receptors, are classified as position sensors. So the statement that I said is coming from that whenever your body is signaling that when you are doing one particular activity and you are getting pain, that means that is the signal to stop, because that is the position sense that the body is giving you, that while doing that exercise you are not comfortable. So the take home message for me is to go gradually. So what happens in the gym usually is your first day at the gym and you try to do everything in that 45 minutes. I will run also, I will do resistance training also, I will do flexibility also. But it is according to the patient. So every client is different. So for every client you have to have the customized protocol. And if you are developing any pain, that is going to lead, even that little bit of soreness is going to cause a lot of hampering of a function of the fascia, as well as a sort of inflammation that also goes on. And if we do not take care of that, then the problems with the muscular dysfunction starts. And that is why I said that whenever you are going for the exercises, please see to it that you do not develop any discomfort and soreness while doing that.
But the concept of DOMS, the delayed onset of this, so I'm still able to understand how do because generally that's what I have seen, that people do feel little bit of
Sweet
soreness
pain.
who are inactive when they
But
start.
that soreness has to be taken care of by doing relaxation exercises, by doing cool down. So if that soreness has been taken care of by doing cool down and the relaxation exercises, and you are not going home with any aches and pains, that means you have done your workout well.
But DOMS sets like after 12.
Domes should not set, ma'am. If you are getting the domes, that means your exercise intensity is a lot that your body cannot do it. And that is a strict no when we are progressing, especially when we are talking with the patient clientele who have already the low grade inflammation. Setting the domes in them is strict no.
Okay, so they need to do exercises in
Yes.
such a way.
So beforehand only
So
we need to
reduce-
take care of. So when we are doing the resistance training, we have a measurement that we call it as a repetition maximum. So we do that RM testing for our patients. When we are doing the aerobic exercise protocol, when we are setting up, we need to identify their intensity at how much. So we have a Astron Time protocol for them. So we make them cycle and we judge different parameters. And depending on that, we give them the intensity, and depending on that. And that is what the dialogue with your patient is very, very important. When you are doing this exercise, are you comfortable? The observation of your patient when the patient is into that exercise, that the form that he is maintained is right or no. So all that matters. And if you follow it very vigorously and rigorously, then the DOMS doesn't set in. That is what my experience is. Yes.
Okay, thank you.
So
Can I
this
ask
is
one
for
more
Dr.
question?
last question and then
Yeah,
move on to
yeah,
the others.
sure. Yeah, last question. So you also can you also tell us the frequency of fascia release, basically when in general the exercise has been done, daily exercises, daily flexibility and everything. So is there any thumb rule?
Yeah, at least twice a day, ma'am. As I said, when you are doing your regular workout, before that and after that, warm up and cool down. If you do all these exercises, will be take care of your entire body. That
Thank
is
you so
enough.
much. Yeah, thank you so much.
Yes.
Yeah.
I
This
have a
is for Dr.
question.
Mittal. Can I?
Yeah.
This
Yes,
is for
ma'am.
Dr.
Yes,
Mittal.
sure,
A very
sure.
nice and short and comprehensive talk on this sarcopenia. May I just know, how do you really assess this muscle mass with that exascan and all you routinely prescribe to the patient? Which patient categories you will specifically order to look for the muscle mass and strength before you start with the management? And how will you monitor it later?
So thank you very much for that question. There are various measures we can use to look at the lean body mass, right? So one measure is what is commonly being used, which is based on bioelectric BIA, right? There are a number of equipments which are there. Some of the gyms have that equipment. So in our clinic, actually, we are having that body comp analysis equipment. So we use a particular machine by a Japanese vendor called Tanita. It is a machine with a lot of publications also. So what we are trying to do is we do a body comp analysis of all our patients before we put them on any kind of anti-obesity medications, and then we kind of follow it up, because that number gives the patient an idea that okay, this is what is happening to my muscle mass, this is happening to my fat mass, this is happening. It calculates the indexes and everything, gives you the trends and everything. So that is the thing what we do, which basically is simpler, right? For assessment of visceral fat, you can actually just do a waist circumference, waist hip ratio. That actually can give an idea, 80 centimeter, 90 centimeter in females and male respectively. That can give an idea, right? And then there are some, apart from that, the next step is the DEXA. DEXA gives a proper body composition analysis, which actually is a better technique than BIA, but it becomes slightly difficult to do on a day-to-day practice, right? Even better than that is MRI, right? Where it can MRI, CT, where you can actually calculate the visceral adipose tissue, you can actually calculate a lot of stuff. And with MRI, you can even calculate the intramyocellular fat component and everything, right? In an OPD basis, you can do simple things like calf circumference, you can do how much time, sit to stand test, which are easily available, then hand grip measure. All these measures which can be done on an outpatient basis. But if say somebody is running an obesity center and can invest a little bit in terms of body comp and everything, then that becomes an added tool, because that's like a objective measurement with a printed report where patient can see what is happening in terms of the figures and everything. And otherwise DEXA, once you tell patients that this is why we are doing DEXA, right? It's important. And it's also indicated not only in these, but it's also indicated in elderly people, where you feel that a lot of our diabetics are frail, elderly, where muscle mass actually is very, very low, and to convince them to change their dietary habits or to do any kind of exercise is very difficult. So that again is a way to kind of the clinical diagnosis. The clinician always knows that there is sarcopenia which is there, right? And it's not mandatory to do the diagnosis, but that report gives the patient an idea. Oh, this thing is low. That is why I need to do this. It's like patients, once they know my HbA1c is high, they become slightly more careful, right? It's like that.
Yeah.
Yes, but the basics remain the same. The basics are whether you're resistance training and protein intake, as we discussed elaborately in the presentation. The basics remain the same.
Nowadays, hand grip meter is used mostly in clinics, like nutritionists use it, physiotherapists use it to understand the muscle mass.
Yes,
so it's
yes.
more easier and cost effective. Any other question? Yes, ma'am.
So I don't think there is a randomized trial, but to little bit of my understanding, magnesium glycinate helps more in the sleep part. It does have an improvement of muscle function. Magnesium oxide salt does better in terms of muscle function, muscle cramps, etc. We use it a lot in patients with muscle cramps, along with vitamin E and optimization of calcium and vitamin D. It does help.
Yeah, ma'am.
Once we start anti-obesity treatment, how we should assess the patient, like after how many days we will go for the assessment by the body impedance, or again we will do this?
So body comp analysis you can do early also, but typically we are doing it at 3-monthly interval, right? So you can apart from that, the other assessment needs to be more frequent. Like you can do other assessment, like what kind of side effects the patient is having, whether it's a GI side effect or other thing. Do you want to titrate the dose or not? What kind of a diet the patient is following? All of these things are very, very important. And I think obesity is a very continuous process, right? And it does not end with medication. Medication is just one part of the whole story, right? It's, lot of pieces of the puzzle are there, and medication is just one part of it. Diet is one part of it. Exercise is one part of it. Behavioral aspect is very, very important part of it, because, a lot of our eating is actually, frontal cortex driven, right? So it's very, very important, because otherwise what will happen is patient will lose weight and will bounce back. We don't want a bounce back, bounce in, bounce back, right? So I think it's the more the time the patient is spent with the patient, realizing what the whole complete thing, as Vaishali ma'am is talking about holistic approach. That is something which is very, very important when you talk of obesity.
Namrata, I have a question for you. You mentioned about walking.
Yeah.
And you said you should not use the ankle shoes. So, what kind of shoes? Because most of us feel walking is an exercise here and we all walk with
Correct.
shoes on. Which shoes are right shoes to walk?
Ma'am, if you have any knee problem or a hip problem, I guess the floaters or the flip flops are the good shoes. Yes. But if you do not have any knee problem, then the walking shoes, what we use as a sports shoe, is a good option to go for. An ideal one is a bare feet walking that we should do at least at our homes. We should walk bare feet. Yes. That has a tremendous advantage for the loading. Yeah.
Any more questions from the audience? Ma'am? Thank you very much, Dr. Sachin.
Thank you.
and Dr.
Thank you so
Namrata.
much. Thank you.
I think just wait on the stage to felicitate. Can I request Dr. Vaishali Madam to come and felicitate?
So I have the pleasurable duty of inviting all the dignitaries. Can I have the chair? Yeah. So basically, this is for the first time that we have written book on wellness assessment. So usually illnesses we have lot of books, but we don't know how to assess health of a person. And assessing health of a person needs a lot of inputs from the neuropsychiatric as well as the physical point of view. And Padke sir and team CBM has done a fantastic job of compiling it into a book format. It will be soon available online on Amazon, but this is a formal launch for the audience here. And as physicians also, I'm sure we don't know how to know whether the person is healthy or not. We usually give fitness, knowing at the back of our mind that the patient is still not fit. And the way to assess the fitness is through this book. It emphasizes, I would like to, Dr. Padke sir to give some review of this book. So basically, this book is going to give us a view on how to assess health in a person who is not ill or who has achieved control of his illness. So if a diabetes patient is under good control, does that mean he is healthy? No. You need to know how to assess the health of that particular patient. And this book is going to guide you on this. And it's a very simplified version of how you can do it on a clinic based, you can say day-to-day activity. Like it can be taught to your educators, not necessary that doctor has to do it necessarily. So, Padke sir, would you like to tell some words on this?
Yeah, in short. So, as you all are aware that for last several decades, the World Health Organization has been trying to tell us about what health is, health definitions and health concepts and ideas. So, I was just telling the audience that the World Health Organization has for several years been talking about these concepts, that understanding health is important. But the practical step, a simple practical framework which can be used by the clinicians, by the patients, even for surveys, it was not available. And it is essentially, actually, you can say a translation of the ideas of my teachers, most importantly, Gangadhar sir, who has been emphasizing, that health is, of course, body and mind together, and that there should be some simple way to assess that, because the modern medicine has gotten really excellent about measuring disease, but we are not so great at measuring the health. So what actually health implies, and can we measure it in a simple way? So it's like, you can say, it's a first effort towards that, because operationalization is necessary. Merely by saying that health is not merely absence of disease, but a sort of a ideal state of physical, mental, spiritual, blah, 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 well-being is not sufficient, does not help us on a practical level to measure it. So you can say this is our provisional effort, is based on, principally based on Gangadhar sir's ideas that we need to measure health, and we need to measure health holistically, which means that we need to measure it, mind and body together. And the measurement should be so simple that it should be one transdiagnostic. Means not something, which is only related to some disease diagnosis, but should be applicable trans-diagnostic and trans-speciality. Whether someone comes from an endocrinology background or someone comes from a psychiatry background, everyone should be able to use it. Second is that it should be simple enough that, because the purpose of measuring health is not only for research. In translation, in day-to-day clinical practice and even in population surveys, even patients should be able to make use of it as a feedback for themselves. That today I stand here, this is the health standing that I have, and that I have to now gradually move towards a better health. Another significant enhancement, technically it's called as an incremental validity, which we have tried to bring into this framework, is the idea called resilience, beyond normal health. Because now we have this understanding that we can inculcate or we can develop this ability, that our health could be better than the so-called normal health. And perhaps it is the resilience which gives us ability to some kind of a protection, which is offered health terms is by this resilience. So this is a simple scaling available in a graphical way, and the parameters which it has used have been derived from multiple sources, principally from large-scale epidemiology studies. So studies done on millions of people. So for example, it has shown that sleep is a very important variable. Good sleep is a necessity for, as a, you can say, an important pillar of health, like that. So the parameters which it derives are from large-scale epidemiology studies, as well as has a lot of research base. So in that sense, I would say that none of them have been invented by us, but we have sort of compiled, this particular approach. And moreover, it is modeled after a very important scale that we often use in clinical trials called the clinical global impression, which allows us to sort of summarize, the health status of a person. It was last month, it was officially published in NIMANS in the presence of my most important gurus and colleagues there in NIMANS. But Vaishali madam thought that this is a very important occasion, because just before this session we had a meeting upstairs which she will inform you about, that how we can contribute together, the psychiatric society, the endocrine society, towards a new sort of a, you can say, a higher objective of Healthy India. Not just, disease-centric, disease focus, but Healthy India. And that's why this is a sort of a provisional resource. She thought it's a good idea to expose all of you to this resource, so that from this point, we sort of take it forward. So thank you, Vaishali madam, for this opportunity and for this good idea, that we showcase it here again.
So I would like to declare the announcement of a concept group. Concept group is a group which is going to work on collaboration and a network of obesity. And this is going to involve multiple societies. And today is the day when the group will start functioning under the guidance of Dr. Gangadhar sir. So basically, so can I request Dr. Makhdoom sir and Dr. Marwale sir also to be here? Dr. Marwale sir is Secretary of the Indian Psychiatry Society, and we heard Dr. T.S.S. Rao, the President of Indian Psychiatry Society, who agreed to wholeheartedly support this movement of obesity network. And Dr. Makhdoom sir is the President of Maharashtra Endocrine Society, and he has full-heartedly supported this moment of obesity collaboration across national specialties. So please have a seat, sir. So can I ask the dignitaries to hold this book and have a photograph, group photograph on this? Yes. Thank you so much for sparing their valuable time on a Sunday, and I'm sure that all are very in a hurry to go to their respective flights. So thank you all dignitaries for being here on a Sunday morning, and we continue with our program. So over to you, Utkarsha, you can carry this forward.